providing oversight of clinical education, epidemiology, safety, accreditation, risk management, quality improvement, and nursing. She leads the development of our new patient safety and risk management education for all lines of business and collaborates with key individuals within our organization to facilitate the delivery of high-quality educational programs. She is a registered nurse and a certified professional in healthcare risk management and in nursing professional development. She earned a Bachelor of Science in Nursing degree, a Master's degree, and a doctoral degree in education and healthcare leadership from Nebraska Methodist College. She did come down from Nebraska today. They're going to have a rough day tomorrow. I have a feeling that prime time is going to sweep the floor with them tomorrow in Boulder, but she's a good sport about it. So,
we're going to have a rough year. We've had a rough 10 years, but we'll make it. Can everyone hear me okay? All right. So today, Sherry told you we are going to be talking about soft skills with a focus on how can we prevent medical malpractice. Well, in reality, we know we can't necessarily prevent a malpractice claim, but we can reduce your risk exposures, reduce the opportunity for something to pop up. What do I mean by soft skills? Soft skills kind of covers a broad range of things from empathy, humility, active listening, communication. Today, we're really going to focus on that communication piece, and not just communication with our patients, but actually communication with our healthcare team. And in a medical school and residency, there's a strong focus on those hard skills or occupational skills, which there should be. We want people who are knowledgeable out there taking care of our patients. But sometimes those soft skills kind of get put off to the wayside. And you'll see some statistics throughout this program today that show that does happen. And within your packet, I'm told you guys are given a QR code, or you have the opportunity to be able to access the slide set if you want to. And I'm not sure if the hyperlinks in your QR code or in your packet are actually active links that you can click on that will take you to additional information. That slide set that I provided has more slides than what I'll be going over today, because I wanted to give you guys the additional information, the research, the data behind what I'm talking about today, so you can do some additional research on the topic if you want to. If those hyperlinks don't work, you can feel free to email me and I can shoot you over a PDF of the slide set that has active links in them. In medical school and in residency programs, like I said, there's always been a focus on those hard skills, and the soft skills kind of got left behind. In 2015, they did start requiring some of those soft skills to be evaluated in entrance exams. So they've made some headway from that perspective. And now they're starting to integrate more soft skill training and education, both in residency and also out in the community. If you Google CME programs, you're going to find, even since COVID, kind of an explosion of soft skill type programs that are available out there. And some of these skills don't come naturally to everybody, and that's okay. They can be learned. You can get better at them over time. So let's go ahead and get started. Why do we even care about communication, and how is it reflected in med mal claims? Well, what we find in the slide set that you have, the next slide actually has the data set in there. When a suit is filed, there are contributing factors. It's never just straightforward, we amputated the wrong leg or we gave the wrong medication. It's never that cut and dry. There's always contributing factors. And in 46% of our cases, we find that communication is an issue. Now, it's not just communication with patients, it's also communication within the healthcare team. And so that's why we know it's an issue. This closed claims data set was actually published in 2003, and it includes data through 2021. The previous version, I would note, our communication contributing factors accounted for 44% of our cases, so we're going in the wrong direction. We need to make some changes and we need to intervene, because, in 2 years when we crunch this data again, we don't want to be sitting at 48%. We want to see a reduction in communication as a contributing factor. We need to make some changes. So we use Cradco, or Candelo is their new name. So we use Candelo to evaluate and dig a little bit deeper into our closed claims data. And what we found is that 57% of those cases that had communication as an issue, it was a provider to provider or a healthcare team communication issue, while 55% there was a patient provider communication issue. Now that doesn't add up to 100% because in 12% of those cases there's overlap. It involved both of those. And the thing that I would really, I need a pointer. The thing that I would really point out on this slide, because it's pretty close to an even split. We see issues on both sides of the fence, but in our healthcare team communication issues one, that accounts for 73% of our total incurred losses. That's significant. And then on the patient provider communication issues, that's 43%. And then there's the 16% where it's kind of shared. Now, the communication issues among team members that I'm talking about might be things like critical test results aren't communicated, or a treatment plan isn't shared with the entire team. So it's communication issues, communication breakdown issues among the healthcare team members. While with the provider-patient communication issues, it typically has to do with health literacy. Whatever was shared with the patient wasn't shared in a way that they fully understood, or that that was executed in a way that the patient could follow through with instructions. So we see they're both issues, but today I'm really going to focus on that team communication issue. And I'm going to touch on those patient issues. I'm going to give you some strategies to communicate with your patients in a more effective way, but the true focus is going to be that team communication. And unfortunately, one of the things that we have amongst our masses is behavior that contributes to those communication issues. So now we're going to be talking about inappropriate behavior and disruptive behavior. Now, some of you may have just shut down and said, I'm not disruptive. I don't have any behavior issues. This doesn't apply to me. And in reality, it does, because when you have one person on your team that has disruptive behavior, it affects the entire team. It changes how that team functions. And we're going to talk a little bit more about specifically what those disruptive behaviors are, because often when people think of disruptive, they're thinking of the big outbursts, or the yelling, or the things that everyone is talking about in the hospital when they occur. But it's actually a little bit more than that. The AMA actually defines inappropriate behavior as conduct that's unwarranted and reasonably interpreted to be demeaning or offensive. Now, that's pretty broad, and what's offensive to me might not be offensive to you, and vice versa. So sometimes that's kind of a moving target to figure out what's inappropriate. Obviously, if you're questioning in your head whether or not you should say or do something, clearly don't do it. Take another path, because in all likelihood, that's probably one of the behaviors that's in that gray area. Now, for disruptive behavior, it kind of takes it a little bit further. We're talking about abusive conduct that the intent is to harm or intimidate the other person, and typically leads to a patient safety issue. Now, they further split up that disruptive behavior into 3 buckets, and I'm actually going to talk about them in reverse order. I'm going to talk about those aggressive disruptive behaviors first. Those are the ones risk management gets called about. The angry outbursts, the misbehaving in the OR, raised voices, demeaning behavior, things that intimidate. These are the things that most people, you hear, oh great, Dr. Brown, I hope there's not a Dr. Brown in here. Dr. Brown showed up today. We're not sure who we're going to get today. Are we going to get happy Dr. Brown, or are we going to get angry Dr. Brown? Oftentimes those are, I see some people giggling, and I'm assuming it's because you guys have a Dr. Brown in your area that it's hard to pinpoint who you're going to get. Those are the types of behaviors that they really do need to be addressed, but they're easier to identify. When we start looking at these passive-aggressive behaviors, the excessive sarcasm, I have a sarcastic sense of humor, so I have to be really careful with who I'm I'm being sarcastic with, because it doesn't always translate. It doesn't translate culturally, and sometimes it just doesn't translate. Even within my same culture, people don't understand. I was just kidding. And especially when you're talking about patient care and you're talking specifically about a patient, kind of set that sense of humor, or that coping. I use my sense of humor as a coping mechanism. When I get stressed out, I'll make jokes. Sometimes they're sarcastic jokes. In a stressful situation, if that's your way of dealing with things, make sure you're setting that sarcasm to the side, because we want to make sure that our communication is very clear, especially when we're talking about patient care. We don't want to leave something open to interpretation and assume whoever the listener is knows exactly what you're talking about. There's also implied threats is another thing to consider. Now, these aren't going to be over you're physically going to harm someone. It might be I understand what policy is, but this is what I want you to do. And there may be an intimidation factor there where an employee feels like, okay, I have to do this because I have to keep my job. If I don't follow orders, or if I don't follow this specific process, there's going to be personal implications for me. So that's what we're talking about for implied threats. They might not just be outright, you're going to get fired if you don't do this. Refusal to complete tasks, or condescending language or tone. The passive disruptive behaviors are those that are insidious. Those are the ones that, as a risk manager, really concern me, because I know people are telling me about these aggressive ones over here, but these passive ones are ones that just kind of inch their way in. Incomplete charting. Well, how does that affect me? I complete my charting every single time. But if you have a colleague that's late to chart and doesn't get their charting in, they're affecting your ability to see the whole patient picture. And so these types of behaviors can and will affect you at some point in your career. Avoidance is another one. Failure to answer calls. If you ask nurses, that's one that really concerns them, is when they call someone, they're calling because they have a reason to call. They're unsure, or they need something from you. Frequent absences, chronic tardiness, getting behind. We've all gotten behind. From an administrative perspective, we know some of these things are not within your control, but if you bring them to attention to administration, hopefully they'll work with you to try to work on if you're getting behind because you have too many patients on your schedule, your acuity is increasing, so you have to spend more time with your patients. Those are things that can be resolved, but they are considered a disruptive behavior. We also have, I'm gonna put a pin in that. I'll talk about that in a minute. Our best estimate is that about 3 to 5% of our physician population has disruptive behavior. That's not a lot. If we look around, 3 to 5% of us, that's not a whole heck of a lot of people. But the impact, again, has a wave effect. So just because it may not be you, it doesn't mean you're not going to be affected by it. It doesn't mean you're not going to be named in a lawsuit that involved a disruptive provider. And you don't want to be put in that position. And so we'll talk in a few minutes about some things that you can do to protect yourself when you have one of those people on your healthcare team. And keep in mind, it's not just physicians. You can have staff members, nurses, nursing assistants. Disruptive behavior can affect everyone, and it also applies to everyone. So administratively, when we are looking to hire someone, there are a few red flags that we look for in credentialing files. And these are some of them. Now, in them, each item in itself may not be an issue. Frequent job changes. If you're married to a military spouse, that could easily explain your frequent job changes. You want to move with your spouse. A history of investigations. Well, that's not necessarily concerning. What we're looking for is patterns. So just to reveal a little bit about me, I've been investigated by the Office of Civil Rights as well as by the State Nursing Board because a patient was upset because my name was on the termination letter when we terminated her from our system. So she filed some complaints. These investigations are not quick, and they are required. If a patient complains or if there's a concern, they investigate whether you did anything wrong or not. Now, in my situation, it took about 2 years to get the Office of Civil Rights out of our business. They did find that there wasn't anything amiss, but during that time frame, I had a 2-year period where if I went to go look for another job, I would kind of feel obligated to let them know there's an Office of Civil Rights investigation going on. Did I do anything wrong? No, my name just happened to be on the chart. So when you have credentialing departments reaching out to you and asking you for information, you don't need to be ashamed about the information that's out there. Make sure you share it with them so that they can put it into context, because if they undig it and if they're digging along and they find it, that's going to make them feel a little bit very different about looking at your file. Why didn't they tell me this? Why are there 3 investigations going on? And how come it wasn't included in this application? If you are ever in a position where you are helping to decide if you're going to onboard someone and you want to bring on some new physicians, I would encourage you to connect with your credentialing department and ask them, what are some red flags I should be looking for? And if you ever have any kind of pit in your gut and you want additional information, don't be afraid to ask. Ask for clarification if the dates don't line up. Those types of things are important because you need to feel really comfortable with everyone that you're pulling into your department, because you're going to be working with them on an ongoing basis. So there are also some contributing factors to disruptive behavior, and I kind of touched on this a little bit earlier, where you've got Dr. Brown coming in and you never know who you're going to get, a little bipolar, not sure if we're going to get happy or sad today. In some cases, there are legitimate mental health issues that need to be addressed. These are fixable for the most part, but sometimes the people who are this 2 to 3% that are in this bucket, they might not realize that the behavior or whatever they're doing is impacting how you do your work. There are also personal issues that can come into play, and oftentimes what we see is if somebody has a concerning report or they have some they're exhibiting disruptive behavior, if it's like episodic, sometimes there's something going on in their personal life that's an additional stress and they're not coping as well as they normally do. The family issues might be happy stuff. You might have just brought a baby home. That's going to mess everybody's schedule up. It's going to change how you communicate. You're not getting as much sleep. It could be a wedding, legal issues. Maybe you were named in a medical malpractice lawsuit. Even if standard of care was met and your attorney tells you this is not going to go anywhere, it still plays with your mind. You're going to be thinking about that case all the time. You're going to be thinking about, well, I should have done this, or next time I would do this, or how come this didn't happen? And it's going to be a constant in your mind. And medical malpractice cases can sometimes last several years. So that's going to be looming in your head. And heaven forbid you get 2 filed against you, because then you start to question even why you chose medicine at that point. Burnout is something that you guys are going to talk about a little bit later. COVID really affected burnout in the healthcare profession across the board. We're seeing doctors and nurses leave the profession. They're reducing their hours. They're looking for alternative ways to practice so they don't have to get in that situation again where they're working day in and day out. And it's easy to do. And even now, what I'm seeing, at least from a nursing perspective, is they put all of these incentives out there, mostly financial incentives, to get people to pick up extra shifts. And now they're wanting to hospitals are needing to take back those incentives and cancel those incentives because they can't afford them anymore. But nurses won't pick up these extra shifts because, they've tasted the extra money and they want to keep it. And so but they're burning themselves out in the process. Physical health is another factor. When I was with the health system, I would see physicians, one in particular who had MS, and we had to keep constant tabs on this provider, not because they weren't a great provider. They were very skilled in what they did. The problem was when his disease process progressed, we had behavior issues pop up, and those needed to be addressed. He needed to go on leave until we could get those resolved. And financial problems are another one. But I don't want to glaze over the substance abuse and use one on this slide. Now, not everyone who has disruptive behavior is a substance abuser, and not everyone who uses substances moves into that disruptive behavior bucket. But there are some people who take medications, they're legally prescribed, they're taking the medications, and it alters something in their personality, it alters something, how they communicate. A good example would be sometimes fertility drugs will alter your ability to manage stress, make you a little short-tempered. Not everybody, but it can happen, and it's important to make sure that you understand, especially if this disruptive behavior is just out of the blue. Someone needs to reach out to that person and try to figure out what the issue is so it doesn't progress to a constant or a normal state of being for them. The Joint Commission has published several documents about disruptive behavior. Obviously, it fosters medical malpractice, medical errors. It decreases patient satisfaction. One of the data slides that I've included in your packet includes a study where 9% of physicians accounted for 50% of the complaints. And so if we can address those 9% of the physicians and help foster their communication skills and get them to a better point, we're going to decrease our patient complaint volume significantly. It increases preventable adverse events. So on this slide, what I've done is I've actually added patients to this one. The research shows that if you have a disruptive patient, either on your unit or in your practice, or a disruptive healthcare team member, doesn't matter who it is, there's a 42% chance, more likely chance that you're going to make a diagnostic or a diagnosis error. It's going to decrease performance across the board. There's an 11 to 14% higher chance that there's going to be a medical complication. And this last one, almost a 32% more likelihood you're going to have a complication risk with that patient. And I would say if there are behavioral reports on file. Now, so in a few minutes, we're going to be talking about some reporting processes you can implement to track those behavior records. 4 seems like a lot. Hopefully, we are addressing these disruptive behaviors before we have 4 on file. But I would also say, as far as patients go, as a risk manager, I can't tell you how many times where I had a physician come into my office and say, we need to terminate this patient. They are rude to the front desk staff. They speak terribly to the nurses. They're non-compliant. They're a terrible patient. We need to get them out of the practice. And so I say, okay, let's pull up their record. You pull up their record and they're perfect. They don't do anything wrong. There's nothing documented to support all of these problematic behaviors that apparently have been going on for a really long time. You've just hit your frustration level and you want to get that person out of the practice. That Office of Civil Rights situation, that was the classic example of that. If we don't have sufficient documentation, it makes it more difficult to defend that type of case. So if you have a disruptive patient in your practice, I would highly encourage you to engage risk or call your med-mal carrier early on to talk about the behaviors. How do you document those behaviors? You might want to consider some behavior contracting that gives the patient some very clear rules. This is how we play the game, and if you violate this, the implications are you'll be terminated from this practice, or you'll have to transition your care to a new provider. So it's really important that you're making sure you're getting things documented so that risk can help you, or so that you have enough sufficient evidence if something is filed against you, abandonment or something like that. About 8% of physicians are sued annually, And your odds actually increase if you have some behavior-based issues. Some of these, you're 6 times more likely to be sued if you don't consider other people's suggestions. So if you have a specialist that you're consulting with and you completely ignore them, or if you have someone on the healthcare team and they're calling you and they need something and you're ignoring that, you're 6 times more likely to be sued. You snap at others when frustrated, you don't pay attention, doesn't inform others of the treatment plan. That's an example of that would be, I don't have time to document today, I'm just gonna go home, I'll document on another day, it's in my desk, I'll get back to it later, and it doesn't end up getting entered in the chart, or the patient seeks care another avenue, and this set of healthcare providers don't have your information from earlier in the day. And then talking down to others is another factor that will increase the likelihood that you will be sued. So personally, I have to do a time check real quick. All right. I'm a storyteller when I present, so I always have to make sure I'm not going down a path I shouldn't at the wrong time. So early on in my nursing career, I had been a licensed nurse for 2 years. I showed up for work, all ready to go during a snowstorm, to find out that no one else showed up. This is a metro area. It's got, we're a medical hub. There's lots of healthcare providers, but when the snowstorms hit, if you show up, you're probably going to be one of very few that do. So I showed up. They were trying to be really creative with staffing. With 2 years of experience, I was the senior nurse on the floor. They were adjusting. It wasn't my floor. It was a transitional care unit. So they moved me down to the transitional care unit. I had 3 patients, but I was doing IVs for the entire floor because I was the only RN. They pulled in a couple of LPNs, and they had a bunch of nursing assistants they were able to get in touch with were able to come in. So people-wise, we had plenty of people to take care of these patients, and we were doing a fabulous job. About 2 o'clock in the morning, I had my 3 patients that were my primary patients, and I had finished all the IVs, and I went to sit down to chart right outside one of their rooms, and she flips on her light, and I thought I was disturbing her because I'm out there tapping, trying to get all my charting ready and complete. And I asked her if she was doing okay, and she's like, well, I just feel different. And so I go into her room and I take a look at her. She had been in the hospital at this point close to 3 weeks. She was getting some IV antibiotics. She had a ton of IVs, and that's one reason why she was assigned to me, because I was the only one that could administer IV medications on the unit that night. And when she was originally admitted, she was admitted for some cardiac reasons. She was moved down to the transitional care unit because she needed to get her IV medication, mostly antibiotics, completed before she got discharged home. And so I took a look at her. I had taken care of her 2 other times during that time span, and I did notice her skin coloring was a little bit different. It wasn't like, oh my gosh, you look a lot different. She just looked, I couldn't even pinpoint exactly what it was. She just looked different. And she kept telling me, it just feels different up here. It wasn't pain. I did, checked her vital signs. I was doing all of the cardiac checks. And actually that's where my brain was going, was something was going on cardiac wise. That's why she was admitted in the first place. So I go back to the medical record and I'm trying to figure this out, looking at her past vital signs, her labs, if anything had changed over the past few days. There wasn't, again, nothing was jumping off the page, but she just kept telling me she was uncomfortable. There wasn't anything on her medication list that would address an uncomfortable feeling in her chest. She had some cardiac things, but I went ahead and I called the cardiologist at 2 o'clock in the morning. I told him what was going on. I told him I was actually hoping he would order an EKG or some testing, or actually move her back up to the telemetry unit so they could monitor a little bit more closely, especially since we were so short-staffed. So when I gave him my full long report of everything that was going on, and he said, "Did you know she had GERD?" And I look at my nurses are given a care plan at the beginning of the shift that has like a summary of everything that's going on, and that wasn't on there. There were no medications to indicate GERD had been an issue, and it hadn't even crossed my mind, to be honest. And I go, "Oh no, I didn't know that." And he goes, "I can't believe you called me for GERD at 2:00 in the morning while I'm doing a heart cath." And he hung up the phone. Before he hung up the phone, he had actually yelled at me for about it felt like forever, but it was only for like a minute. But he was yelling at me, insulting me. He couldn't believe that I had done this. And so with all of my 2 years of experience and my wisdom, I sat down at the chart, and it didn't even dawn on me that that was not appropriate. What he had done to me was not appropriate. I sat down with her chart, and I'm like feverishly looking for that GERD diagnosis and who I can call to try to get her in a spot where she was more comfortable. And I'm looking through the chart, and about 2 minutes later, the house supervisor came up to me, and she's like, "How's it going?" And I'm thinking she's talking about the entire unit because of our staffing issue. And I start spittling off, "Oh, we're doing great. Everyone's being a real team player. We're getting things done." And she goes, No. I mean about this patient." And the first thing that popped into my head was, he called and reported me because I'm a terrible nurse. I was embarrassed. I was humiliated. And so I start giving her a summary of everything that I looked up on the patient. And she asked if she could go take a look at the patient. And I'm like, "Yes, absolutely, please." And she goes in and takes a look at the patient. And she comes out and she says, "We need to get this patient transferred." And she makes a couple of calls, gets the patient up to the telemetry unit. And within about 30 minutes, she coded. Then she was sent down to the ICU. She ended up in the ICU. Well, over the course of the next several days that I had worked, I got compliments from the chief medical officer, the chief nursing officer, of course, my boss. Other people were coming up and saying, "Good job on identifying that in your patient." But I can tell you, all of those kudos didn't matter, because the impact of getting yelled at when I had a concern about a patient stuck with me the rest of my career while I was taking care of patients. I always hesitated to call a doctor, especially if it was in the middle of the night. I wanted to make sure I had sufficient information. I wanted to make sure that the care plan I had enough information on it to be able to get the patient what they needed. A situation like that never happened again to me, but that one time affected my response to all of the other patients that I took care of when I was taking care of patients. And I can tell you, it was somebody in the cath lab. It was the cath lab team that actually called the house supervisor and told her what happened. It wasn't the physician who called and ratted me out. And so with that being said, Vanderbilt actually has a process. It's called Coworker Observation Reporting System. And what they have found is when they implemented this system, actually, the interesting thing is this 3%. They found that 3% of their medical staff, which include their advanced practice providers, also had patterns of behavior issues. So that's consistent with the other studies that we've seen where 2 to 3% of our population is the one with the actual behavior patterns and issues. But within their program, what they did was coworkers, colleagues had the ability to report disruptive behavior. With that, a peer is the one that addressed the issue. And when they set up this system where if you observed someone behaving in a way that was inappropriate, they empowered people to be able to go up to that person and say, "Look, Sherry, that didn't." I saw what happened in there. It didn't exactly go as we expected. What's going on? You sounded like you were pretty upset, pretty frustrated. And it gives them the ability and the power to be able to get to the root. And when that behavior is called out at that time, they saw a 71% rate where providers didn't have an additional report. So they were able to nip those behavior reports in the bud just by calling it to their attention. Because a lot of times risk doesn't hear about it right when it happens. If you see it, do something about it, say something, call it out, make sure whoever did it knows that it's not an appropriate behavior and not an appropriate response. Another part of their program is this approach, which if you look at the bottom part of the triangle, that's kind of what we just talked about. It's that coworker reporting system where if you see something, take them out for a cup of coffee, go have lunch with them, find out what's going on, let them know that whatever is going, even if they don't want to share what's going on personally or professionally or how stressed they are, calling them on it and making them aware that we can see something's going on and you need to make a change does make a difference. And then using this pyramid as you go up, if a pattern starts to occur, of course, that's when you pull in an authority figure, either a department chair or someone from risk, to be able to make them officially aware that it's an issue. And then if the pattern persists, of course, you progress to potentially some disciplinary action at the top of the chart. But the foundation is the really important part. If we can mimic that study at Vanderbilt, we have the potential to impact that 2 to 3%, hopefully, improving behavior and how people actually respond. So now we're going to talk a little bit about some solutions. The research shows that during medical education and residency training, the empathy actually decreases. That doesn't mean you guys aren't empathetic or that you've lost those skills. The research just shows that that does decrease when you're focusing so much on those hard skills. And so being self-aware and knowing what you're good at as far as your soft skills goes is really important. If you're not sure, talk to somebody, talk to a loved one, talk to a coworker, find out, ask them to be completely honest and say, am I good at active listening, or am I good at explaining things? So find out where your holes are and seek out education or training or someone to mentor you in those areas. Sometimes it feels awkward to ask somebody to help you to do those types of things, but it really will make you a better healthcare provider. It'll also reduce your risk exposures as far as medical malpractice goes. The next couple of slides in your packet go over communication strategies with patients. We're familiar and comfortable with the healthcare environment, but when we have a patient come into our setting, they may be ambivalent, they may have never seen a doctor before, never had a surgery before, and so there's a lot of anxieties that sometimes, since we are so comfortable, we kind of forget about, or they might have some sensitivities that to us is no big deal. You walk into a room and a patient has a patient gown and you can see everything on the back end. Well, for you, it's no big deal. You've seen a lot of those, and it one way or another, it doesn't bother you, but that can really impact the patient. It can embarrass them, humiliate them, and so it's really important to put yourself in their shoes. How would they feel? Somebody who's not familiar with the healthcare environment, and communicate with them in a way that's appropriate for them. One of the challenges I have when I go into a doctor's office, either with my mom and dad or for myself, is if they find out I'm a nurse and that I'm old and that I've been a nurse for a really long time, sometimes they talk above me. It's been a long time since I've taken care of an actual patient, so sometimes they'll start talking about very specific lab values and how the mechanism of how a medication works. And it's been so long since I've played with that type of information that I have to have them dial it back. So make sure that when you are talking to your patient, don't ever assume they either know something or that they don't know something. It's kind of a fine line. I would not be offended if someone told me the very basics and spoke to me as though I had no medical knowledge. And I get frustrated with my mom because she'll be like, my daughter's a nurse. And then they talk to you a little bit differently. And I don't want that. I want to be told the same information that you would tell any patient, especially because I'm here with my mom and I'm just here to support my mom. I'm not here to make the decisions for her. And so just make sure you know there are patients who have clinical knowledge and they do want you to speak to them in a certain way. Field them for that. Talk to them in the way that works best for them. This is another slide that just talks about various communication strategies you can use with your patients to improve that communication. Now, surgical teams are a little bit special in that they have a lot of transitions that occur. They've got pre-op, intra-op, post-op. They've got stuff that happens even before the patient shows up for a procedure. And so there's a lot of opportunity there for communication breakdown. And you're also working with other teams. So you've got your office staff that you're working with, and you've also got that surgical staff or the surgical team that you're working with. And then once the patient is discharged to a unit, you've got that group of people that you're working with. And so there's a lot of opportunity to miss the mark as far as communication. And there are quite a few resources out there to improve surgical team communication. And on one of these slides, there's actually a link to Team Steps communication. And you may have heard of some of the Team Steps strategies. SBAR is one of those. CUSP is one of those. They've got lots of different acronyms out there. But I would encourage you to get very familiar with what those strategies are and make sure that you've kind of fine-tuned your communication within a surgical team. These strategies also apply to people who don't work in a surgical setting. So I did include them. I left them in your slide set. These strategies, which we're going to talk about a little bit, some of these strategies on the next slide, are additional resources that are available to you. And again, if the links don't work on your PDF, shoot me an email. It's christine.hoskin@medpro.com. So my name with a dot in the middle. And I can send you the hyperlinks to all of these resources so you can dig a little bit deeper if you want to. But that Team Steps communication that I was talking about is right here under Culture of Safety, because really that's what we're looking for. We're looking for a culture where everyone feels like they can raise their hand and voice a concern. Another Team Steps concept, they call it Stop the Line. Typically you see that in like the surgical area, but truly what we want is we want everybody to be able to raise their hand and voice a concern, patient safety concern or a process concern, and not feel like they're going to get yelled at or hung up on when they do have a concern. They all need to be addressed. Now, from an organizational perspective, what we've got or what we need to see out there is obviously a code of conduct. Now, if you've ever read a code of conduct policy, you know they're written at a very high level, and they don't really give you concrete examples of things to look for. But if you know what your organization's code of conduct looks like and what issues are problematic, you're going to be at a better position to be able to address issues when they do pop up. Part of the policy and procedures should be something about addressing disruptive behavior. How does it happen? You need to check with your organization to see, do they have a reporting process? Do you go to your department chair? Do you go to risk? Do you enter it into a database somewhere? So familiarize yourself with what the policy and procedures are, and keep in mind that the process might be different for physicians than it is for staff. But if you have a staff member that their behavior is problematic or concerning, familiarize yourself with that policy as well and go through the proper channels to make sure those are captured and addressed. Most organizations have a medical executive committee, and hopefully they have leadership support in reporting disruptive conduct. Occasionally, we see organizations where the disruptive provider might be on that committee. And so that gets a little bit challenging, and that also corrupts culture a little bit, or quite a bit. Make sure you know who's on your medical executive committee, and you can gauge whether or not you have leadership support when you identify an issue. Is it acted upon, or is it brushed under the table and ignored? That physician is a really high producer, so typically nothing ever happens to them. They do a ton of surgeries, they make a lot of money for the organization, and it's ignored. I've worked in organizations like that where behavior is dismissed because they are a high producer, high volume provider, which is quite unfortunate. I even had one, this is where I do stories all the time. I even had one, he was a cosmetic surgeon, and instead of actually reading his charts, he would literally chart in his record, signed but not read. On everything, and there wasn't anything that we could do, no strategy, risk tried to get this healthcare provider, this physician, to change his ways. And unfortunately, even trying to go through these medical executive committees and trying to force change didn't work initially. Eventually it did, but it took a lot of work because he generated so much income for the organization. So early intervention and monitoring, that's what we were talking about a little bit earlier. Not all organizations have a formalized program like Vanderbilt, but that doesn't mean you can't do it. That doesn't mean you can't reach out to somebody. If you see a concerning behavior, reach out to them, let them know you saw it. It might be an isolated incident and nothing ever happens again in the future. And if so, you did a great job. That's exactly what we want to see happen. Call out the behavior, talk about it, and hopefully they can self-regulate and change their behavior before they get stuck in that 2 to 3% bucket. And then we encourage, of course, staff education and training. 25 years ago, things were a lot different back then. And it didn't even occur to me as a staff nurse that a physician hanging up on me and yelling at me on the phone was wrong. Common sense now is like, no kidding, Christine, how come you didn't pick up on that? But things have really changed. Now, if that happened to me, I probably wouldn't react in the same way. I would have made an additional call right away. But we need to make sure that staff, and whether you're consider physician staff, advanced practice providers, the hospital staff, everyone needs to be educated on what's okay and what's not, and what is the reporting process that needs to be followed when these situations occur. And of course, team training always helps. If you have a cohesive team and you all know each other, it's a whole lot easier to pick up on the changes in behavior. It's a lot harder when you're working with different team every single time and you're like, oh, is Dr. Brown always that way? And sometimes you're not comfortable actually saying it or coming out and pointing it out, especially if you're the new kid on the block. But really, everybody needs to be empowered and everybody needs to have some form of training and be familiar with the policies and the processes and the chains of command. We need to make sure that our handoff procedures are really tight. They're in place and that everybody's doing it. I know people get frustrated when someone from administration says, we've got to standardize this. The reason why we push standardization is because we need to make sure everybody knows what to expect and everybody is doing things the same, so that when you are searching for information in the medical record, or you're searching or you're doing a procedure, we need to make sure that everything is getting checked off and everything is being done in the same way, so that we don't get in a situation where, whoops, we forgot to check the right site for surgery, or we forgot to, no one told me about this medication that was changed on the patient record. So it's really important to know if your organization does have a specific handoff process that you are following it. And I know within a lot lot of EMRs, there are usually designated areas for to document certain things. As annoying as it is and as non-intuitive as it may seem to you where they decide things go, it's really important that you stick with that, because if you were in a position where you were searching for a specific piece of information and you know it's supposed to go here, then it actually benefits you when that occurs. And then ideally, organizations should be publishing culture of safety surveys. Those culture of safety surveys typically, well, it depends on where you're at. Some do them about every 3 years. And the reason why you could do a culture of safety survey every year, but culture is one of those things that it's very slow to change. So if you did a culture of safety survey every single year, the movement on things is probably not going to show you a lot. But when those surveys are done, what you want, a healthy organization is actually going to make progress based on what their culture of safety survey said. Typically, there are questions about, depending on where you're coming, there are several surveys. One might be geared towards physicians, one might be geared towards nurses, but the root is to figure out where those culture issues are. And I can tell you, when you are in an organization, if you're ever in a leadership role and you're looking to dig or to learn more about some of those culture issues that could really make a difference, I would encourage you to reach out to your nurses. In one of the slide sets that's included in this survey, one of the things that popped out was nurses were really able to identify those process issues or organizational level issues that contribute to communication errors, because they're taking care of the patient. They see the patient through the entire process, whereas a physician comes in and they're involved in the care and they're overseeing the care, but then they have to go to another patient or they have to go back to the office practice, whereas the nurse kind of sees the whole picture. So involve them, and they can usually give you a really good idea on how healthy the culture is within your organization. So to tie it up, and I'm actually really impressed because I'm sitting at the 50-minute mark here, I'm going to reiterate that 46% of rate for communication contributing factors in a lawsuit. We've got to get that done. We've got to get that taken care of. And I think the best approach is to be able to nip it in the bud like Vanderbilt did and implement a system where everyone feels comfortable calling people out when there is disruptive behavior, and when appropriate, make sure that it's getting reported to either risk. Every system kind of has a different process. Sometimes you go through the department chair, but familiarize yourself with what that would look like, and feel comfortable reaching out to see if somebody does need something. Does anybody have any questions on anything that I've gone over? All right. I can't believe it only took me 15 minutes. I hid like 20 slides, all the data slides, because I'm like, I'll talk too much. All right. Well, then it looks like I'm not in charge, but you got 10 minutes.
Regulatory matters and advises. up when we have an issue, and so I am happy to be able to present her expertise to you all today. So, Corey Lewis.
All right, thank you guys. I thought I was going to be the first speaker. I should have known doctors get up. You guys start everything way early, right, Sherry? What did you come over the night before?
Yeah,
okay, well, all right. Well, thank you guys for having me. I love the name of the Is There Life After Residency? Yes, there is, and it's going to be great. Aren't you guys excited? So we're going to go over, do I just use the mouse? Okay, I'll just click right there. Contracting issues. My dad's a doctor. My brother's a doctor. I work with PLICO and the OSMA a lot. So this is kind of, I do healthcare law. I represent other types of providers as well, but physicians is kind of my niche area, and contracting issues, employment issues, that type of stuff. And it's changed a lot over the, as Sherry kindly pointed out, the almost 3 decades I've been doing this. So we'll just talk about some of the practical issues. We're going to go over, like Sherry said, employment agreements. That is the predominant model these days. 74% of doctors now are in some sort of employment model. Again, that changed. My dad was in private practice in a small town. So that is, over this span, has changed a lot. Doctors used to be all pretty much small business owners, and now you're in an employment model. But there's still some medical practices that operate independently in various models. And so we'll talk about, buy-in issues, if that's something you're interested in, physician-hospital integration, and then just briefly mention kind of a new trend is these big private equity firms buying medical practices and things like that, and just to be aware of it. So on employment agreement, just some top things, and not necessarily, this one I put kind of common mistakes, and we're kind of back into some of these issues, and it's not an advertisement. You really, whether or not you consult an attorney, but the reason I put this one up front is because if you're going into something, usually in today's world, if the hospital, if you're going to go into an employment, all of a sudden that got weird. An employment agreement with a hospital, St. Francis, Integris in Oklahoma City, they have their contract templates. And they're not going to say, oh yes, for you, we will do a whole new contract. It doesn't work like that, unfortunately, these days. They've got, their attorneys, their teams of attorneys have written, this is their model. And so, but that doesn't mean there's not things in it that you can negotiate. They're just not going to scrap the 20-page document and start over, is what I'm trying to say. But there's terms within it. And most importantly, is getting someone so that you understand it. I can't tell you how many people just, this is a template. They're not going to change it, so I'm just going to sign it without understanding it. And usually, okay, things rock along. It doesn't become a problem until it becomes a problem. And so it's important going into something that you understand the terms of it. Just expectations are huge. And you just want to know what, especially the compensation formulas, which are complicated these days. That's important. You want to know how you're going to be compensated, what the criteria are, that kind of thing. So oftentimes, though, if you wait until the very end to have it reviewed or for yourself to sit down and take the time to review it, you've gone kind of to an awkward place in the communications to where you're having to back up with them and say, and they're going to say, we thought we had an agreement. You already signed the letter of intent. We're going along this. So if you're going to, make sure you start in enough, at a process where you can make some changes if you want to. Also, it's important for another reason that a lot of times you go to your recruiting dinners, you do all this stuff, and maybe there's things that you've talked to the employer about verbally, but it's unique to you. That is a unique thing, and it's not in their template. I don't know, some examples, maybe if you have large systems have multiple sites, and you really preferred and you've been recruited to one site, but I guarantee you there's usually language in their contract that says, at our discretion, we can move you wherever we want within our system. If it's with a large system, you say, but I have kids and I want to be within 15 miles of their school in case there's an emergency, or you have your reasons, then you may need to put that in the contract. or if they won't, like I said, a lot of times they won't change their template, but they will sign a letter agreement or a side agreement or addendum for that specific. So again, you don't want to have verbal agreements that do not get reflected in writing. If it was important enough for you to bring it up, if you said, hey, I was trained on this new piece of equipment that's new. You guys are young doctors coming out of medical school. Your facility doesn't have it. And that was a verbal agreement that you said, yeah, we'll buy you the equipment. Then you need probably to have that in writing. And those are the type of things that unfortunately then come back after the fact for young doctors. Well, I was recruited here and they said that they would remodel and I'd have this extender, a mid-level hired, and none of that's happened. Well, let me see your contract. And they give me the contract and it's never in there. So those are the reasons, if you think you're in some of those situations, that you might want to consult with someone or make sure you've read it early on in the process. Another thing that I always put when I review physician contracts is I have this, kind of standard stuff that I go over with doctors. And I say, first of all, have you done your due diligence? I know you're excited. You want to get your first, full-time job. You've been working your tails off. I understand that through your residency, but the post-residency job. And so have you visited? Have you asked good questions? Because no matter what is in writing, if it's a bad culture, if administration has changed and they're not physician-friendly, if a lot of people have left recently, no matter what in writing, you can't make up for a toxic work environment. So have you visited? Do you know your colleagues? Do you know their history? Have a lot of people left lately? Just understand, a lawyer can't, we can help you with the written terms, but that doesn't mean you're going to be happy in that job if you haven't done your own due diligence. And that comes up a lot too when we get to private practice. Then you really need to, because those that have been able to stay independent of hospitals and and stuff like that, usually these days have pretty complicated business models. And so you want to know going into one of those, large physician groups, or what are you structured? You're hiring me as an employee, but do you have other entities? And we'll talk about that more in a minute too, but you just make sure you've done some due diligence. And that's why sometimes an attorney can help you formulate those questions, because you've been doing medical school classes, not business classes a lot of this time. So you may not even know really the questions to ask. Is this your only entity? Do your owners own other entities where they make more money through those entities than the practice entity? And are you pulling money? So somebody like, an attorney who's done a lot of physician deals will actually help you, or could help you, formulate your questions that you don't even think of to ask. Okay, employment agreements, then you actually get a written document. Sometimes people will say early in the process, will you sign this letter of intent? Those are usually non-binding. Just make sure it has non-binding language in it. And then you may get that, and then to an employment agreement. Or some hospitals or employers will just bypass a letter of intent phase. It depends on how early in the process you've started, and they'll just present you with a draft employment agreement. Like I said, the most important thing is that you understand it. That's what mostly I do these days with physicians in employment agreement reviews. Again, there may be some flexibility where I suggest, hey, I've looked at a lot of these lately and the signing bonus is either not there or is low. So I can help you hopefully, or any attorney can help you hopefully identify some things that, I've checked the MGMA data and this salary seems a little low. Those are the type of things that you can change. But it's also important to just understand some of these terms. Usually there's a lot of defined terms. You have to understand too that the systems, the employers, they draft them kind of one-sided. I mean, there's no nefarious intent about it really, but they want you to represent, and here's what you're going to do, And then when you get to, well, what's the hospital or what the employer is going to do for me? And it'll say, we pay you. I mean, and that's it. So you want to understand both sides of that, what you're representing to. Usually the agreements contain things that you represent and warrant a whole host of things. You know, I haven't had any licensure issues. I finished my residency, blah, 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 and it'll go down that. If there are any things in those that you can't, like if you've had some issue in the past, it's always better to disclose it up front. It's usually not a deal breaker, but I am telling you, even though it's hard, even though if you have anything in, you know, that you can't satisfy those, it becomes a condition that they view as an honesty issue, even though you're like, I wasn't dishonest about it. I just didn't want to talk about it. You know, whatever that is, if it was a conviction, a DUI, whatever, it's better to disclose it up front, because if they do their criminal background checks or their data bank reporting and they find anything, then it's actually ends up being more problematic than if you just disclosed it on the front end. So be aware of that. Also within employment agreements, again, they would be 100 pages if they incorporated everything that all of the terms in the agreement. So you will see things in employment agreements where we do in the legal world incorporate documents by reference. And it'll say, you agree to comply with our policies and procedures. But I mean, you're like, what policies and procedures? You may need to ask. I mean, if they have, they usually incorporate by reference compliance policies. If you're going into a Catholic system, understand they always have that you will comply with our, they call it something, and I'm just blanking, they're Catholic directives, because Catholic systems have unique things, services they will not provide and things like that. So you need to know, okay, I'm aware of that and I can comply with that. I agree to that. So if there's any things like that that are incorporated by reference, you may want to say, can I have a copy? Just so I can look them over. Because usually, again, compliance and agreeing to comply with those policies and procedures, if you don't, they can be grounds for termination at some point. So you want to know, you know, and usually it's stuff that's, you're going to comply with it. I mean, you will be, but it's just good to be aware of it. And like I said, I already mentioned what's not there. Those are sometimes, most often, those are verbal type agreements that you made about specific things. And again, it's not going to be in the template that they just routinely use. So make sure you understand that. Failing to understand the compensation formulas, they get very complicated these days. And usually, if you're going into most Oklahoma hospitals right now, you hear a lot about moving to value-based and all this stuff. Still, the predominant model in Oklahoma is a work RVU formula, where going into it as a young physician, you may be guaranteed a certain amount of income for the first year or two, because they realize a hospital, you're working, but there is a lag in making money for your employer because of the billing cycle. So you may be working there 3 to 6 months before they get any money from your services because of the time it takes to submit claims and get paid and that type of stuff. So initially they are subsidizing you most of the time, and you have to realize that. So a lot of times you will be guaranteed a certain amount of compensation initially in the contract until you're up and running. And then they switch to a work RVU formula, which is based on your production. Or they may start that up front. It's important you know what kind of compensation model. A work RVU formula, again, is a production-based. You're probably aware of how you bill, and they assign these work RVUs to you, and then they multiply that by a conversion factor, and that's kind of your compensation. But these days, there's that. And then there's usually some maybe incentive compensation on top of that. Will you meet certain quality metrics, patient satisfaction? If you are just killing it, above a certain amount, maybe you get additional, or that work RVU conversion factor goes up. Usually I recommend to young physicians, have they presented you with a pro forma? I mean, it's good to see all that written out, but for me, it's easier. Okay, can you give me a spreadsheet that shows if I generate this, I get this amount of RVU conversion factors, my income will be this. If I do this, see it in writing. Make sure you understand how you're getting paid. On a work RVU formula, it's also important to understand, do I get this amount of work RVU when I perform the service, when I record it in the electronic medical record and you know I've done it, or when the claim is dropped, or when you get paid, when you get the reimbursement? That makes a huge difference. You know, what is the timing of when you're going to see that compensation? So understand that. Also understand, you know, of course, things that may negatively affect your compensation. And for, well, you can have maternity or paternity leave these days. Now, so if you're going to have a family, if you're on a production-based model and you're not working, your production goes down. And so that actually comes as a shock to some folks when, you know, they take off a certain year and they thought, well, I've been making this. Well, if it's a work RVU formula and you're not there to generate the work RVUs, you will take a hit. So you either need to negotiate that in advance and say, I will get a minimum, you know, spread out over this time, or you have to save accordingly because you know you will take a dip in the year that you have a family. So understand or start your family. Benefits, very important part of any physician compensation, any employee. Understand what benefits. And again, this is an item that usually is incorporated by reference because employers want to reserve the right to change the benefit package, and that's common. But if you need to understand, okay, well, do I get dependent care on my health insurance? Huge amount. You know, do I have to pay any for my spouse or dependents? What type of disability? It is very important for physicians usually to have, in my opinion, this is, I guess, my opinion, but adequate disability insurance. Because sometimes the package that's provided for the employer will be kind of a standard disability package, and it may be adequate to replace the income of a lab tech or, you know, at the income level somebody else, but it may not be sufficient to replace a surgeon's income or a high-performing surgeon. And if you've got expenses and you're out there and you're used to working or having a high income and you, heaven forbid, are injured or disabled for a time period and you need to replace your income with your disability insurance, you need it to be adequate or as close thereto or have savings to replace your income. And so be aware of that. Things happen. We've had, you know, doctors out with long-term COVID. You can get, the most common, ironically, that I keep seeing are doctors that go skiing and hurt their hands. Well, a surgeon can't operate with a thumb that's been back by a ski pole. I mean, weird things. So you want to make sure you have adequate disability and stuff like that. Also, you may need to think about earlier in your career, if you haven't already, getting with a financial planner to help you because hopefully, you know, you're all going to make good incomes and that type of stuff, tax planning, estate planning for your dependents, how you're going to invest the money and save and all that kind of stuff. So think about those things in advance as you go through there. But disability, your 401k, you know, savings, again, is the hospital or your employer, is their retirement plan what you expected, or do you need to supplement it in some way? Like, do they match it all? How much in their 401k or whatever will they match? And is their plan going to get you to where you want to be at your retirement? I know you're young. I mean, thinking about these things in advance, you're like, probably, I don't need to worry about that now. But I'm just telling you, the sooner the better, usually on those type of things. I already kind of mentioned this, just, you know, not understanding the terms, not recognizing that the agreements, you know, may not always be, they're going to be most beneficial to the employer. And I mean, that's just how you negotiate and that's how things work. And sometimes physicians just expect, you know, why wouldn't they just give me the, you know, the best offer they could? Well, that just doesn't work like that. So just recognize that. And especially these things, and this is again where somebody outside, attorney or somewhere that's really business savvy could help you, is looking through. And when you're going into one of these contracts, it's hard to understand that read and review the contract to determine what's going to happen when the contract ends. Because no one thinks, oh, that it's going to end. Maybe that you think it's just going to keep going, but understanding, okay, when I go into this, I need to understand what happens when this contract ends so you can protect yourself from negative things. One thing, example, tail insurance on your liability insurance. One of the benefits you need to verify, obviously I think 100% of employers, if you're in an employment model, they're going to provide your liability insurance. And you do that. Question though comes up, what type of policy are they providing you? And what happens when the contract ends? They tie together. There's two types of liability insurance policies. One is called claims made, one is called occurrence. Back in the day, again, this is one of those things that has changed over time. Here in Oklahoma for decades, and it's considered the gold standard of liability insurance, would be occurrence. And so the key to that is that you're covered from, you start your job, you have an occurrence-based policy. What that means is it will cover anything that occurs during the term that policy is in effect. The reason that is important is you may already know that you can be sued for medical liability negligence for years after the event occurred because of the statute of limitation. If you're in pediatrics or treat minors, it can be as long as 18 to 21 years, the time period during which you could be sued for an adverse event. So so the best type of policy, the gold standard, is one that covered you for anything that occurred while the policy was in effect. You don't need what's called a tail insurance policy if you had that kind of policy, because if you had the insurance when it occurred, it would cover you. The problem with that is a lot of those policies don't exist anymore because it became actuarially hard to predict, and for insurance companies to predict how much reserves they would need because of the long statute of limitations. And so most often, or oftentimes now, what you will have instead is what's called a claims made policy. That means that you have the policy, but you have to file the claim during the time the insurance is in effect. The problem with that is if you leave employment, you change insurance companies, that policy is not in effect anymore, and you could be sued off into the future and you don't have coverage anymore. So that what addresses that issue is an extended reporting or tail policy, is what it's most commonly called just in the vernacular. You need a tail policy. Okay, so here's the situation. You need to review the contract to say, usually the contracts will say, we will provide you employment, or we will provide your liability insurance while you're an employee. If you change, you have to buy the tail. The tail policy can be 1.5 times 1 year's premium, which is usually not an insubstantial amount. So you need to know, I think you need to know going in, so that if things, you just need to be aware, hey, if I ever want to decide if things aren't going well, if I decide maybe I have a better opportunity over here, one of the factors that you need to take into account is if I leave, do I have to buy my own tail? And you have to be prepared for that, because it could be $30,000, $40,000, $50,000 that you owe your back employer. It's also a point that can often be negotiated, though. And what usually I see is, okay, either they pay the tail, or at least as time goes on. If you've worked for them for 5 years, they have been able to probably make money from your services. You've been, a good employee. They should pay your tail after a certain period of time. Or it's something you need to negotiate with the employer going to. Is like, look, I'd love to join you, but I'm going to have this financial hit over on here because I have to buy my tail. Would you help offset that? So just those are the type of things going in so that you can better protect yourself later. The area that you usually can negotiate are just some of those extra things. Does your contract include a signing bonus? You're kind of already past this point, but sometimes, especially if you're going to rural areas, it's not uncommon for some hospitals to pay stipends even during your fellowship and residency to help support you. And then, or your student loans, do they include help with repaying any student loans? You can get terms like that oftentimes. Be aware though that sometimes when you get benefits like that, they will tie it to kind of like how long you work for them. They'll say, we will pay you a signing bonus of $50,000, but if you leave within 5 years, you have to pay a pro rata portion back. Like every year they will forgive $10,000 and you work it off. So you got to understand, again, that would be something, okay, in advance, if I get in this and I have one of those provisions in my contract and I decide to leave after 3, I may owe them money back. So you got to know, going into those type of things. Another thing that's often in employment agreements are restrictive covenants. What does that mean to you? Know that in Oklahoma, this is a Oklahoma specific thing. So if you leave Oklahoma and go to another state, you need to check what that state does in this. Covenants not to compete in employment agreements, pure employment agreements, are not enforceable under Oklahoma law. They may be in your contract. A lot of employers especially will put them in there for, thinking that, hey, they won't know that they're not enforceable, and they'll adhere to them out of more fear and things like that, and they won't compete. They are not enforceable under current Oklahoma law. There's also a national federal trend to do away with covenants not to compete. We'll have to see how that, but in Oklahoma, as long as I've been practicing, they're not enforceable. They're considered a restraint of trade, and you can't enforce them. But what is enforceable are other types of restrictive covenants, like a non-solicitation clause is enforceable. A non-solicitation clause means it usually says in there that if you change employment, if you leave our employment, you will not take with you our patients. And this is sometimes hard for doctors to understand because you view the patients as your patients. They come to you. Your employer says they're our patients. And so they say you cannot, solicit our patients to go with you or our employees. Those are enforceable, usually. And what that can trip you up is, well, what's a solicitation? If you have a good, relationship with your patients and they Google it, which is so easy today, and they find where you go and they follow you, you didn't solicit them. Solicitation is an overt act like, I know I'm leaving, I've given my 30 days notice or whatever, and I'm giving you my new business cards in the waiting room on your last visit, or I contact you, or I try to copy, get on the computer and copy down some addresses. That type of stuff is what they consider solicitation. Any questions about employment agreements? Yes, sir. Yeah. What I recommend is if you know you're leaving and you've given your notice, to coordinate with your employer on what they expect, just to eliminate, problems. Because in today's world, especially, I know in Oklahoma City, they would say that we're going to have a problem with that. They would tell you in some cases that I've been, privy to, they will say, we don't want you to tell them anything. Because they're our patients and we will contact them and we will reassign them to one of our other physicians. So literally that is very hard for physicians to think because they're like, I have a relationship with this person and the next time they come, I'm just not going to be here. They're going to see somebody else. They would not want you to even tell them they're leaving. Yeah. Yeah. So coordinate that is the easiest way, and communicate with that with the employer on, can I at least tell them I'm leaving, and just communicate often is the best. I've had some in the Norman, Oklahoma City area that would call the doctor's next employer and tell on him and say, if you're switching, this is just an example, from Norman Regional to Integris, one of those, the counsel for one would call the counsel for the other. This is just, and say, we'll file an injunction against you, the next employer. So it causes problems for your next employer too, because that's usually how they handle it. So just communicate through that. Somebody else, I saw, yes, sir.
I'm curious, if you tell them, hey, I'm no longer working at this place as of October 31st, like, well, where are you going to be? Can you get away with, oh, just move?
That's, yeah. I mean, I would do that before I'd give them a specific address. But literally, I've had some that they don't want you to even say anything. Yeah, I mean, and yeah, it gets pretty ugly at some points. And so just be aware of that issue. Some people are more gracious. Some people will work with them on a letter to patients, and, you know, we'll collectively work on it. But especially if it's a really competitive type practice and they want to retain all those patients, you will see, unfortunately, an ugly side of healthcare sometimes in those situations. Because if it's really competitive and they want to keep the patients in their clinic, they won't want you to say anything. Yes. Huh?
What does an injunction do? Like, why does that on the brief afternoon?
I mean, it's hard. I mean, an injunction, you know, they'll file a lot of times. Yeah, practically, I mean, are they going to go file and tell you not to do what you do? Like I said, they usually figure out other things to do. They'll call the place they know you're going and cause problems that way. Or they'll, you know, sometimes you have language in there with a financial penalty that you will, you know, that if you do, they'll just withhold money that under the terms of the contract. So you have to just read the contract and see what they've said. I very rarely do see them actually go get an injunction because that is in effect. I mean, it'll say in the contract they can. And certainly if you're really doing something overt like sending out letters using their mailing list, they can enjoin that. That's usually not what happens, though. It's more of these things. So it becomes a practical issue more than a real legal issue. But it's unpleasant. It's unpleasant for the doctors that are, you know, trying to do that. You know, I like the patients. They like me. You feel that's just one of the unfortunate, that's where medicine and business don't mix sometimes very well. Okay, practice buy-ins. I said I'd go over this a little too. If you're in a situation, this is, you know, like I said, it used to be every physician. You did not have an option of employment, you know, 20, 30 years ago. You would become a small business owner. You would go get your loans and you'd start a business and you'd buy equipment and that kind of thing. That really isn't the model now. But there are some large physician groups that are independent still, quasi-independent, and or, you know, there's some still smaller practices or maybe some sort of specialties that do more like plastic surgery, cosmetic surgery, those type of things that's more not payer, so tied to payers, and you don't have to have the sophisticated IT and billing systems. And so there's practices like that if that's your area, this will still apply to you all. And those type of arrangements are varied. And this is where I said this is definitely one area where you may want to really check with an attorney, because the models and the organizational structures of these type of arrangements are getting very complicated and they're varied. It's not as cookie cutter as going just, you know, into an employment model. So understand, and if you are, a lot of times these days, young physicians coming out into a private practice situation, they will employ you going into the arrangement with some thought that after you've worked with us, then you get to buy in to the practice. So you want, but it's amazing how many times that is definitely a situation where I get things kind of too late in the process. Like, I've been an employee here for 2 years and they told me after 2 years I'd get to buy in, and I'll say, well, okay, send me the employment agreement, and the employment agreement won't say anything about the buy-in. So then you have a verbal agreement that in 2 years you'd be allowed to buy in. So the number one thing is, if you're going into that type of situation where you have an expectation that in a certain period of time or at a certain level of productivity or whatever, you will be granted the option or the right to buy into an entity, get that in writing, or at least get some notion. Now, they may, you know, what is you say in 2 years I get to buy in. does that depend on what if I do have an accident and I'm not as productive? Will that get delayed? Is it based on the revenue I've generated? Is it based on the work RVUs I've generated? Is it just a 2-year, in 2 years I'll be buy-in? If it's a large practice, does it have to be a unanimous vote of all the partners or does it a majority? No going in, so you don't have negative, unexpected negative surprises where all of a sudden, what if you don't vote me in? Does that mean I'm terminated, or do I just continue under the employment agreement for another year? Know those things going in. Even if it's not binding and you can't get them pinned down on those type of things, at least get some generalities in writing. Also, this is where, especially you may need to get tax advice on this, because there's different, and we could do a whole thing on corporate law, but just understand there's different types of entities. So that would be important from your tax perspective. Is it just a normal corporation, the entity, or is it an LLC? LLCs have what they call pass-through tax treatment. So all of the money comes out. You don't get separately taxed at the corporate level. It just comes out. Some of these arrangements want you to form a PLLC, a professional limited liability company first, and then your PLLC is the owner of the practice, not you personally, not Jane Smith. You need to know that. You need to form your PLLC. Just by way, this is an aside, but it gets Oklahoma, we don't do things normally a lot of times. You will ask, do I need to form a professional corporation or a professional limited liability company? In Oklahoma, the laws state, for whatever reason, licensed professionals can form a PLLC. And then that means that nobody else that's not licensed can own part of that professional entity. A professional entity can only be owned by licensed professionals. And even certain, like an attorney and a doctor can't form a PLC together. It has to be all doctors in one and all of that. So licensed, but you don't have to. And that's what's weird. People don't understand that you can just form an LLC too. You don't have to be set up in a professional limited liability company. But if you want to be exclusive, meaning we don't want anyone that's not a professionally licensed ever to have part of our entity, you form a professional entity to keep others out. It's very weird. So that's that. Also, if you go to other states, some states have very restrictive notions of, they call it the corporate practice of medicine. And licensed doctors cannot be employed or in an entity with non-licensed. Oklahoma does not enforce that either. We don't have that concept. So those issues may come up if you cross lines. And this is where I come into some of these models to stay independent these days because of reimbursement, regulation, all of the things that make medicine so dang complicated these days. Your more successful private practices are usually now diversified in some way. And so this again is where you would have to do your due diligence is, okay, you're recruiting me to come be employed by orthopedic specialist of Utopia, whatever, that entity. And I am employed by orthopedic specialist Utopia. But what you don't understand maybe coming in is where they make their real money is that those owners of this practice also own an ambulatory surgery center, or they own over here too. So you would want to know coming in, when do I get to buy into those things? Because the practice, if you're in an LLC, remember, you're going to put you on a production formula. You're going to eat what you kill. That's what we say in the legal world. You produce. So there's not going to be a lot of money left over in that entity. Usually at the end, they distribute it all out under your production formulas. So it's not like you may make some extra money at the top from the next recruited doctor. But other than that, sometimes the money is in other entities. So know that you have to check all that out, ask those questions up front. Liabilities going into these situations, again, due diligence. Have you been subject to payer audits? How profitable is this business? Can you show me some financials? Do I know what I'm going into? Or especially the young people. If it's a lot of older doctors, I'm telling you, you do not want to be funding somebody else's retirement. If it was my sons, I have 3 sons, that's what I'd tell them. I mean, if I'm the older and I'm in the place where I'm like, yeah, I would like, and a lot of these practices, because if they've really been in existence a long time and they haven't updated their models and their corporate documents, in the old days, that was fine. That you would be basically the young people coming in would then buy out the older doctors, and it would be expensive though. That your buy-in amount, and that's what you need to also ask up front. Okay, is what I get to buy in 2 years. What does that mean? Does that mean I've been working for you for 2 years, so you just give me shares in 2 years? Or are you, I mean, a very rude surprise is if the young doctors don't understand, you can buy in, but it's going to be $500,000 or more. And you're like, wait a minute, I didn't understand that coming in. So you need to know, what is the buy-in I'm going to be expected to come up with in 2 years? And is it I'm buying out the oldest doctor and I'm giving them their retirement? Well, in that model, you don't want to be the last doctor there because there's going to be nobody to buy you out. So you got to understand the dynamics of that going in. Have you had compliance issues? Does this entity I'm buying into have debt? Because these days, every bank, if they loan money to a physician practice, they require every doctor in that group to sign a personal guarantee. So you need to know going in, well, you bought this fancy MRI and I'm going to be on the hook. Part of the documents they're going to hand you is, here's your subscription agreement. Here's your, you're going to own these shares. Oh, and the bank wants you to sign off that you're personally liable on this $2 million debt. You need to understand those things going in. Have there been lawsuits? Is it as make sure, is it as profitable as they've told you it is, and things like that. Just understand the documents you'll be given, a subscription agreement to get your units or your shares, depending on what type of entity is, and then are you going to be given a purchase agreement? Are you going to have to literally buy in? Understand, again, just for your education so you don't get mixed up corporations. If it is a corporation, the correct legal terms, or you get shares or stocks. In a limited liability company, you'll get membership interest or units. A lot of people in the medical profession use those. They'll refer to it as stock when it's really a limited liability company. That's why you need to do the research, because lawyers know this, and it's very important to us to use the right nomenclature. But, others, we don't expect others to. You just need to understand what you're getting to. What type of governance, if you're buying in, ask for copies of it. Where is your stockholder agreement? Where are your bylaws, your employment agreement, your deferred compensation agreement? Like I said, it gets very complicated. Some individual private practices have very complicated document structure. And so you need to be aware of all of those. A stockholder agreement, you may buy in, but they may have side agreements on right of first refusal. You can't just freely sell your stock in this entity to anybody. It has to be either first to other members of the group, and then it has to be pursuant to this formula. So that is why these things get very complicated. An agreement, the governing documents of a limited liability company or a PLLC will be referred to as the operating agreement as opposed to the bylaws. So get those documents as well. Major issues in any type of buy-in, the buy-in terms. And by the way, I probably should have said that. I mean, these concepts really apply to any type of entity. We're talking about your practice buy-ins, but doctors can be very entrepreneurial these days. So this would be if you're just investing in anything, a restaurant chain or some totally unrelated business. These things still apply to those. What are the buy-in terms? If you're buying in, who makes the decisions? I mean, that can vary wildly too. I'm going to buy in at a third, but do I have votes as a third? Or some, in this world we live in now, sometimes you'll have non-doctors, business people setting up deals and offering them to you all, and they retain the control. So you may be paying 25%, but you may have 0 voting rights. And you need to understand that going in, that you're a passive investor. So you need to trust the people you're investing with in those situations a whole lot. Transferability of ownership. A lot of times, doctors, again, when you get things pretty complicated, you'll do some estate planning, you'll do some financial planning. You may want to set up some trust eventually for your family. And you can have, a lot of times the documents will allow you to transfer the ownership to a trust of certain entities. Some will not. So you need to understand that. Compensation allocation of expenses. Of course, you need to know, how am I going to get paid? How is money distributed? How much expenses does this have? Again, some of these setups, I mean, if I showed you an org chart, you'd be like, holy moly, because they will have, here's our practice entity, but we have a management company that really manages it, and we have an employee leasing arrangement that provides the employees. Well, guess what? Those are expenses that come off the top. We pay our management company first, those are all things, and then it's only what's left that gets divided out to the doctors in this arrangement. And that's why you go back. Remember, I said, understand how many other entities they own, because you could be excluded as the new physician coming in from the opportunity to own the management company. You just own the physician practice, but they paid the management company that maybe some of the senior doctors own first. So again, understand those type of things and how complicated it can be. The expenses, there are doctors that love the fancy offices with the fish tanks in the waiting room and the 76 flat screens. Then there are the other end of the spectrum that the doctors, have, I don't know, it looks like good wheelchairs in the waiting. I mean, you have that spectrum. And so okay, well, that's not important to me. I don't have that kind of practice. I'm not going to be doing this, but I don't want to pay for the flat screen. I don't want to pay and so I don't want those kind of expenses. You have different mid-level expectations. You have practices that are set up to maximize mid-levels, kind of in a pyramid, and they're very high expense practices. And that may be how you want to do it. There are those that are on that lower end that we just bada bing, bada boom, we're getting people in and out and very low maintenance. So understand the expenses and I've had doctors that they hire a barista to come in every morning and fix coffee for their whole staff. And then when they want to go negotiate with the hospital to buy their practice, and they're like, we're not paying for the barista, that kind of stuff. So just understand that. Restrictive covenants again, note this, listen to this very carefully. If you own, I said in the first, covenants not to compete in a pure employment agreement are not enforceable. They are enforceable if you're an owner. So once you become an owner, and if you sell back your shares, you sell back your units to go compete in somewhere else, they can enforce the covenant against you. So understand there is a distinction. Once you're selling goodwill, the covenant not to compete does become enforceable. And then, of course, major tax issues depending on the structure, depending on your situation. And the next couple of slides, Sherry, I'm probably running out of time, aren't I? Oh, I'm talking so fast. Well, another way to look at this is on the next couple of slides. And this is the way lawyers think, which is sad probably, but like I've been telling you, we go into the thinking about how to protect you when things go wrong. And that's why we look at these going forward and you're like, you're negative. Well, sometimes things go wrong. And so go through when you're looking at these arrangements about here are some of the sources of conflict that often arise in practices. And so you need to kind of solve for that in the documentation before you go in. And it's always the number one, compensation expense allocation. If you're in a group practice, it's really hard if you're so far apart on your expectations about expenses, like I just gave you those. If you're, in a 2-person practice with somebody that wants to hire the barista and you're like, no, I want to take that home in my compensation instead. Everybody can go to Starbucks on their way here. You've got to solve for that in your agreements. Departing physician, how many times I said this up front, you want to know some of these agreements were drafted in private practices that still exist are still operating under documents that were drafted when the first founding partners started it in the 70s. They should have been updated. They don't fit today's times. And so some of that, again, is a bad thing for young physicians like you, because you come into the practice, you're gung-ho, I'm going to inherit this. Dr. Smith said he's going to retire in 2 years. I'm going to get his whole base. But you didn't look at the agreement, and it says when Dr. Smith retires, he gets a buyout of a big chunk of change. And that's when the young person is then funding that person's retirement. And you do not want that. So before you go in, you need to say, let's change that. I'm glad to join you, Dr. Smith, but I do not want to fund your retirement at the back end in today's market. It just doesn't work. Understand the tail coverage again, your non-compete. Also understand if you join a practice and an employer, these days, again, a lot of physicians don't understand that the patients are the employers or the practice, and so are the medical records. So again, they're like, well, I'm going to go set up my own private practice. Can't I just copy? I expect all my patients to follow me because you couldn't possibly take the whole volume of this. No, they can make you pay for them. They can say, well, we'll let you pay for them at your expense, especially in today's electronic medical record world. How do you get those migrated over? There's usually a cost to that. So think about those type of things up front too. You can't just take, like in the old days, you can't just say this file cabinet's mine and we'll move the whole file cabinet. So you have to make arrangements for that. The buyout calculations, on-call responsibilities. I should have brought this up on the employment agreement too, because this is in both. Understand what those are, especially your situation. If you're in a specialty that is hard to come by and you're going to, you want to define what are my on-call responsibilities. That may address in those policies and procedures that are incorporated by reference. You cannot be on call 7 days a week. and you want to make sure that you're not worked to death. So, is my call 2 days a week? Is it 1 day? Do I share it equally? Does the group share call equally? Or have you tried to make the senior physicians exempt? And am I going to end up with this huge burden? So understand your on-call responsibilities. Also understand they may change. If you go to an employer and you go there and there's 4 doctors and you think, okay, well, at worst, it's every 4th day. What if one of those leaves? What if 2 of those leaves? So again, it's important to maybe say, don't just say, oh, I share with 4 doctors, because that can change. You say, hospital, I will never do more than 2 days a week in your contract. Otherwise, they can creep up on you and you say, well, you said you'd share call and we only have 2 now. So guess what? You're on every other night. I mean, make sure you understand that going in. Support staff, do you have control over hiring, firing, at least selecting your own mid-levels that you work with, that type of stuff. Outside income and activities. Again, look for that. If you are really entrepreneurial and you want to, at your young and energetic age, moonlight somewhere or develop the next great medical device or whatever it is, those issues should be addressed too in your contract. If you're in an employment contract, it will say something like, whatever you develop while you're our employee is ours. And if you're, develop the next great implant, then you may have issues there. So you need to carve out your outside activities, but also know if you're employed and you moonlight or you do some things that are outside your contract, even if it's permitted, your liability insurance won't cover you. You'll have to have a separate policy. Most often, your employer's policy won't cover it. So understand that as well. Again, going back to the buy-in terms, am I going to buy in at no buy-in? Is it sweat equity, a flat formula? Are we going to have to go out and get a fair market valuation, which also costs money? Understand those going in. Control, who controls this practice? Am I coming in as an A stockholder with full control, or am I coming in as a B or C with no control? Do you have protections as a minority owner? Again, some of these practices, now that we have private equity entering the market, can be very valuable. And if you're coming in and your agreement says you have no voting initially or you don't vote, maybe say, well, I've got to have protection at least if we get $1 billion offer from some private equity firm, I have some share in it or something like that. So be aware of that. Sale assignment, right of your first refusal, and what are triggering events for repurchase where you can be bought out basically without your consent. Understand those things. Valuation, again, sometimes there are compliance regulatory issues that you may be aware of. Have you heard of the Stark Law, the anti-kickback statute, those type of things? I'm seeing some. Medicine is very, very regulated these days. And so also understand that the hospitals, the employers they're subject to laws that prohibit them from paying you for your volume or value of referrals, and it cannot be not commercially reasonable. So understand that hospitals, your employers, they want you, they need you, but there are limits on, you can't go to them and say, I'm a first-year doctor and I want $1 million a year. They have limits, regulatory limits on what they can pay you. So sometimes they have to say, well, we got to go get an independent valuation to tell us that this is fair market value compensation. Understand those issues come up sometimes as well. The transferability, if you're buying into an entity, a practice, or any type of entity, and you want to buy out or you want to leave, understand how you're going to get paid. Does the agreement say they have to pay you in a lump sum? Does it say they have a payment schedule? Have they purchased insurance on your life to pay for things? Would your estate, if you died or during your ownership, would your estate get a payout? Understand all those things as well. Compensation and income distribution in any group is key, very key, because, again, nothing causes conflicts within a group practice or anything if you feel like you're getting the short end of the stick, that you are. So I very rarely see these days where compensation is in any group practice is based equally, because it's never equal. Somebody's going to have a good month, somebody's going to have a bad month, somebody's going to have a baby, or somebody's going to have an operation. And in most medical groups, you need to take care of yourself and have some savings and things like that, because it's very hard and causes a lot of conflict in groups if they're like, okay, our documents say that they still get the same draw, but they have not worked because they chose to go to Vail, they had the ski accident, and now we're supporting somebody else's family too in these groups, because the money you generate in a practice is based on your time, your services. If somebody's not there, they're not generating money. And so you have to understand that going forward. Maybe things happen and your group says, hey, we'll continue to pay you your normal draw for a month or 2 months because that's fair. We like each other. We want to help. Bad things happen. We'll pick up the slack. But if it goes on and it goes, seriously, one practice, I use that example because one practice, a doctor had the ski accident once, but then he kept skiing. And he obviously wasn't a very good skier because he had the same thing happen the next month, the next year. And they were like, come on, we can't keep funding your whole family's lifestyle when you keep choosing to go skiing and break your thumb. Is it production or is it a combination? Again, expense allocation can really jump up and bite people because, again, some doctors in a group, they need to discuss it in advance. I like to practice with 2 mid-levels. Mid-levels are expensive. No, you only need 1 mid-level. How are those expenses going to be attributed? It's usually easier to say, if you want 2 mid-levels and you're willing to pay for them, we'll allocate that whole expense to you and you can do what you want. We're just not paying for it as other members of the group. Or if you want the fancy Bernhardt sofa in your office or whatever, the desk, and you want to go, that is you. I'm going to go IKEA. That kind of stuff. So just allocate that up front, understand how it's going to be or what truly is a shared expense. Restrictive covenants, I already mentioned, in this type of arrangement where you're buying equity, you're an owner, they can be enforced. Another one, I failed to mention, I talked about non-solicitation. I forgot confidentiality provisions are pretty standard and they're also considered a restrictive covenant. You're subject to HIPAA. You know that you can't disclose medical information, but in these type of agreements, it also may include business information. So if your practice, your group, your employee, you've come up with some great templates that you've included in your EMR and you want to take them with you to your new employer, that could be a violation of this kind of covenant. Or if you have some new process that is unique to your practice, understand this could come up. Buy-in mistakes, the number one is waiting too late to negotiate, that you've just made the mistake of, hey, I'm going to be an employee for 2 years under a guarantee, and then I get to buy in, and you didn't talk about it up front. And that's usually, that something goes wrong, or your expectations not met, something like that. It is a good idea. Like I said, those type of arrangements get very complicated fast. An accountant or an attorney, definitely an accountant to understand your tax issues and things like that may be a good idea. Failing to negotiate or review all the documents, not understanding the terms, same issues. Thoroughly investigating the deal, and we've talked about that. Make sure you're getting what you bargained for. We've already mentioned that. Physician-hospital integration. It's getting rare, really rare. I mean, like I said, there are physician groups that are still physician groups that operate as a medical group, but unless you're maybe in a rural area, there is some type of other contractual relationship with somebody because of the payment. The payers will just kill you on your payer negotiations, or frankly, it just becomes overwhelming. A small practice, the overhead to have a person that can actually negotiate with Blue Cross and do your credentialing and do your EMR, it just gets crazy, crazy expensive. So now you may have accountable care organization contracts. You may be a group that's part of a physician hospital organization, clinically integrated network, joint ventures, IPAs, all these different type of arrangements. They exist. They're their own separate topic, but understand and have that expectation going in. I mentioned some of the laws. Healthcare is ridiculously regulated these days. It just adds so much burden and cost into the system these days. And it is sad and unfortunate, but this is just some of the list of things that you have to be aware of going in, that you are subject. So please, before any deal, I mean, I don't know how many, and that's why health lawyers in my field, we feel like we're always telling people no, which is unfortunate and kind of a downer, because they think, oh, we can do this deal. We're going to, make a lot of money, and we've been proposed this. And then you'll say, yeah, that's great, but that was promoted to you by a person who is not a licensed professional, who wants to make money off of your license. And please understand that there's some crazy business deals out there. And they come and they need you way more than you need them. They have a great business idea, but they can't do any of it without a licensed physician to order that lab test, order that x-ray. And guess what? If things go bad, you know whose license is at risk? Yours. You know whose Medicare number is at risk? Yours. Because they're an owner of a deal, but usually it's your clinic that's actually submitting the claim. Or it's your, John Smith PLLC is the one submitting that claim to Medicare. So when they come back, they don't come back after the business owner or the, deal promoter. Genetic testing labs, urinary drug screening labs, our hot button issues that get in compliance, compounding pharmacies. What else? I mean, just be careful if you get deals, because there are deals and then there are, so be aware of those. Private equity, just to keep it, this is something that now is happening, but this is just kind of that now those groups that have managed to stay independent or physician-owned are like, let's let the bankers in New York come in and buy our practice. And they are offering crazy money. Crazy. I don't know if you know the term EBITDA. It's earnings before amortization, taxes, and blah, 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 interest. And they will offer a multiple on the value of that practice that's just like, wow. How do you justify that? And I don't know how they justify it. Some of it, but private equity, they'll come in and you're just, the dollar signs just go like this. Most of the deals that if you're in a practice that starts, courting private equity or coming in, obviously, again, this goes back to they're making money from your license, your services. So they don't come in and offer you those dollar signs without also a guarantee that you will practice in that same situation and make them money for a certain period of time. So, and they will change your practice. They try to squeeze as much profit as they can. That's their business. They don't see the patients. They don't talk to them. So they squeeze every bit of expense out, and they work, so they expect to make a profit. That is the corporate model that you would be entering. Understand that these deals, the ones I've seen at least, are really good for the older physicians. Again, they're like dollar signs, retirement, world, cruise. But they want the guarantee from the younger physicians to stay for a certain period of time. So you're going to be working for them in that model. So you need to make sure you're getting some value out of it and know that that's the deal. So usually I say this is great for physicians at the end of their career. It doesn't look that great for physicians at the beginning of their career. So understand that going in. Any questions about, sorry, I didn't stop after that. I know I'm running out of time. I'm happy to take questions real quickly, right, Sherry? Any?
We actually got
Yes.
So, thanks for all this. I appreciate it. It's really nice. I really kind of like thinking a lot about like trying to do this stuff. Like when in like the interview process, a lot of the time, like I'll be honest, like I'm like some of them have like 4 interviews. No point. I mean, I've talked about like you said, I have good things to kind of try to hang on to about after all those things and the timelines of it, but like. You don't ever actually see, like, at what point, like, who should you bring up? Should it be the COO of the group, the CMO, like, their lawyer, at some point, they're, one of the other physicians in the practice that's interviewing? Who is the person to be like, hey, man, where, like, you talk about every detail, but I've never seen a single detail. Like, I'm not going to roll in, and they're far away. I have to fly to these places.
Oh, my gosh,
You know
yeah.
what I'm saying? Like, I don't want to fly something here and be like, hey, here's the contract. I'm like, dude, none of what we talked about is even anything.
Yeah. Sorry. I'm probably under a thing. Yeah, it is. And if you're going and flying to those places, and again, I know they're taking you to the steak dinner restaurant, and it's a little awkward to say, I would ask as soon. You want the introductory, you've kind of got the feel-good meetings out of the way, but say, as early as you can I see your template? Because like I said, they should have a template. It may not even have your name filled in, but what is your standard? What am I going to be asked to sign? I'd really just like to have time to review it. I may be hiring an attorney. It should not be new to them. So just early in the process as you can, do you mind sharing with me a copy of your template agreement so I can kind of get a flavor for how this, and even if it doesn't include my name, I mean, that this isn't, I just like to kind of see your model. Probably, usually it'd be coming, if you're in an institution, the COO or the actual business people will have that more than the doctors. Again, the doctors are doing their thing, medicine, and they're more there for the let's get to know you. Do our personalities mesh and that type of stuff? But the business office person should have that right off the top. Yeah. Yes.
For hiring lawyers and law firms to do contract negotiations, is that typically like a percent, flat fee, hourly?
It can run the gamut, and I can just tell you what lawyers are expensive. I get it. I mean, there's times where I said, I couldn't afford to hire me. I mean, I wouldn't, and I do, so, I mean, usually I can just say what I do, and I do think it's somewhat unique because I get referrals from, like I said, my dad's a doctor, my brother's a doctor, I've worked at the OSMA, I get it, you're coming out, I will take my hourly rate. That's the benefit of me being at a small firm, is I don't have to keep the same rate. And so my normal hourly rate is really high, but I will say for your first contract coming out of residency, I discount it. And it usually takes me an hour and a half to review it. What you usually get, and I'm just speaking to myself, I can't tell you what other people do, but this is what I would ask. If you go, to another attorney, say, this is what would you do this on this basis for me too. You know, a discounted hourly rate, guarantee, because they're not going to negotiate. But here's how the process works: is you get to that point, you get that agreement, you send it to someone to review it, and then we go through. Do you understand what this means? Do you understand what this means? I have not actually negotiated myself with the other side in years. What happens is you have developed the relationship. I go through the issues and you go back and say, hey, my lawyer said I should ask for this or this. And it's usually the doctor themselves going back. So really the interaction with the attorney in all but the most rare circumstances is, here's the contract you've been given. Here are the issues. Here's some points where, hey, it doesn't include relocation expenses. And if you're going to have to move to that place far away, you need to ask for relocation expenses. Okay. And so the doctor goes back with those things. It is, and oh yeah, we didn't put that in there, because they won't put it in there till you ask for it, sort of thing. Then they'll put it in there. That's how things usually work. It takes me personally, an experienced healthcare attorney that again, this is one of those, you don't want to pay the brand new attorney that will take 8 hours and send you a bill for $1,000. You want one that, has looked at a lot of them. Here's the issues. I can tell them off the top of my head. I went down through this agreement. Here's what you need to think about, doctor. You take it back to that coordinator you've been working with, and that's usually where it is. Yes.
Can you give us a dollar range?
So,
I'm fine with like 500 to 1,000.
yeah, I mean, again, I can tell you what I do, and so you can compare it going forward. Because I know, I mean, I get people, and like I know the bigger firms, they usually send me because bigger firms represent some of the systems, and so they can't represent physicians because it's a conflict of interest. So a lot of my contract reviews come from doctors that had originally contacted some of the bigger firms, and they say, we can't do it because we represent the hospital. So you should call Corey because she can take and do this. And what I do is my hourly rate is usually, over, and I say, I discount it to $275 an hour, and it takes an hour and a half. And so you get a bill for less than $500. That's what. And I usually put that in the engagement letter. I said, this should take, if it is the standard, what I usually do, it takes an hour and a half. I'm going to discount it because you're a resident physician, and I do it for $275 an hour. And so it's usually $275 to $400 at the most, depending on how complicated. Thank you, guys. Good luck.
So you get the blessing of Dr. Tobin, the majority of the visit. I'm just gonna take and I did not set my timer, and so I'll look and see what time it is there. Okay. So as mentioned, I'm an internal medicine, addiction medicine doctor, and really my desire is to share with you just a little bit about my journey and how lack of wellness impacted that, and then share some areas of impact where when you get out in practice, I may be able to be of assistance to you. And so, first of all, I think you guys are all third years, and so that means most of you are about ready to go into, or you're at least thinking about private practice or something else very, very soon. And so congratulations. I think it's amazing. I mean, a great looking group of kids. I know that this is, and you are kids. I'm old. And I know that this is a school that trains residents well. And so I'm personally, as a physician in practice, I'm excited about you guys getting out there, and maybe I can have an afternoon off someday. I doubt it, but maybe. And so let me just tell you a little bit about my story. And so I had an uneventful time in growing up. In fact, basically everything that I did, I succeeded at. I had very few struggles in life growing up. I grew up on a ranch and really was blessed at the opportunities that life gave me. Went to Oklahoma State University as a state officer for the Future Farmers of America, of all things, and went to Oklahoma State University. Graduated as at the top of my class at Oklahoma State. Still, no issues. Really, everything I touched turned to gold. Went to medical school at Oklahoma University. Maybe that was the problem. I don't know. Maybe that was the downfall. But went to Oklahoma OU, no issues. Started drinking just a little bit and started learning some. Really had some unhealthy coping skills in earlier than that, but but I was a tough dude, and I was able to compensate for those, so I thought, and everything still turned out fine for medical school. Went to residency here in Tulsa at OU Tulsa in internal medicine. It was at that point that there was a little bit more issue with poor coping skills, a little bit more drinking. I had this mentality, I work hard and I play hard, and I had this pride issue that I know none of you guys, have this doctor level of pride, but I basically, thought I was my own self-made man, and I was capable of doing anything that the world threw at me. And during those times in internal medicine, a lot was thrown at us. We worked a ridiculous number of hours, and I also trained during the HIV crisis when HIV came back to Tulsa, and the stress of that was pretty significant for all of us, all of the internal medicine residents that took care of a large number of patients that at that period in time did not have good outcomes. And so very, very stressful time in my life. And so started drinking a little bit more, continued to play super hard. I would play right up until Sunday night and then hit it, at 4 a.m. a Monday morning and just, really burning myself out. Went into private practice and it got worse. I'm an old enough internal medicine doctor that I saw patients in the office, I saw patients at the hospital, I saw patients in the nursing home, and there were me and my partner shared call, and so we were basically super sleep deprived, and I joined Catholic Healthcare, and they had a champagne fountain, to welcome us in, and boy, that was it. Just started twisting off at that point, and so it eventually got to the point that that alcohol consumed my life. I a lot longer than it should have because of this pride issue. I was unwilling to seek help. I was unwilling to admit that I had a problem and that I needed help, and so that led to a pretty significant crisis with addiction, and I left the practice of medicine and went back out to the ranch. And I don't know if that was a good coping skill, but it was certainly better than trying to just spin around like I was. So that's my story. That's those of us that are that don't necessarily struggle can struggle with this disease because it is a disease, at any time in our lives. And there are ways to mitigate the disease. There are ways for us to ask for help that allow you guys, because someone's talking about this, to maybe follow a different pathway in a different course, and actually take advantages of what is available for you, and realize that self-care and scheduling time to decompress is just as important as scheduling all of the other things that we schedule as physicians. And if you really think about it, scheduling, there's nothing that you guys have achieved in your life that you didn't schedule in some way. It doesn't, most of things don't just happen by accidents. And so making sure that you schedule time to take care of yourselves, that if you need counseling, you get into it. That if you're struggling with addictions, or if you know a colleague that's struggling with addiction, one of my opportunities is to be here to help you with that, with my role at the Health Professionals Program. And so with that, I'll just tell you a little bit about what the Health Professionals Program does. OHPP is part of the Oklahoma State Medical Association. We are an organization that helps physicians and other doctors, several classes of doctors, find their way back to successful practice from a variety of issues, whether that is addictions or behavioral issues or mental health issues, boundary issues, anything that is knocking a physician out of the best possible pathway, and they're heading in a direction that is gonna not end up well. We help them to get back onto that pathway. We are an alternative to the medical boards. I don't recommend the state medical boards being your first point of intervention. That really complicates your life, and so we're here to help. And so I'm the director for the Tulsa area, and so you guys will have my card, and if you actually maybe you take a picture of it, because you're going to be really, I know some of you guys are going to make airplanes out of it later today and throw them in the room, but if you need me, reach out. I'm here to help. Also, I run the detoxification inpatient and really the largest addiction treatment center in the country. It happens to be here in Tulsa. You're going to have patients that struggle with addiction, and so I'm a point of contact for you for that. And so I'm so encouraged by the fact that you guys are getting a little training on this. I don't know that it would have changed my direction, but I really do believe that it would have, if I would have had any clue about some of the things that contemporary education clues you guys in on, so that you can actually reach for help. And you're not this invincible force that I was trained to think I was. So with that, I'm very blessed to yield the room to my friend Paul, and he will blow your socks off.
That's a big expectation. We'll see where it goes from there. Thank you, Lowell. Let me see if I can kind of take you on a journey over the next 40 minutes or so. And if someone would help me a little bit with timekeeping, I want to save maybe 10 minutes at the end. Just kind of let me know where we are. I've got typically more information than I can share in the short period of time that I have to share with you. I want you to, if you have a pen and paper, draw a Venn diagram on your paper. And basically a Venn diagram is two intersecting circles, if you're not familiar with that. And it's a simple exercise. I want you to think about the Venn diagram as kind of the format or the backdrop for where you are in your lives right now. There is always a we that we're a part of, whether it's in the family we grew up in, whether it's in the organization of the hospital we're joining, whether it's in the practice we're becoming a part of, whether it's in a marriage, whether it's whatever the partnering relationships that we're in. And there's that element of systemic involvement and the influence of that on our lives. And then the other aspect of that is the I. And so the organization that we're involved in, or the relationship we're involved in, and then ourselves. And we're going to be talking about a balance between those two. The blended area in between, if you color code that, let's say one is red and one is blue, the intersection of that would be purple if it was perfect. Okay? What oftentimes occurs is that either my needs, be they selfish or just out of necessity in terms of crisis, may overwhelm the we. More typically, the other aspect of that joining relationship, and especially when it's systemically organizationally, overwhelms us. And I lose me in that we. And so my goal in this whole process is to assist you to recognize under self-care, and a lot of the things we'll be talking about, self-awareness, self-regulation, that I need to sustain a balanced, healthy I. And I need to be able to intersect with whatever that other element is in my life to negotiate for a healthy us. Because I'm a part of that us. I'm not that other person, I'm not that other organization, but I'm engaged with that. And so I'm influenced by that, and I have the need to also sustain me in that process. Hopefully that kind of plays out a little bit as we go through this exercise. Also, it's just my nature to keep things informal, so if somebody has a thought or a question, I did not grow up on a ranch, but I now have 5 horses in my life, 4 that live in our place. And but I grew up in Chicago, and I grew up in Syracuse, New York, and ended up in Oklahoma in 1970, was married somewhat shortly after that, and sort of never looked back. My friends say, Paul, you never really came home. I said, well, I came home to visit, but I was a member of a house of 12 people. Classic Catholic family from back east. I was number 6 of 8 kids, and mom and dad lived with us. So systemically, when I learned about family systems models of understanding our growing up, it just made sense to me. Why do we have to wait to the doctoral program to study that? We should have been studying that in high school. So all of that to say, in the informalness of this, if I'm speaking in a way that you're like, what are you saying, Tobin? Raise your hand or speak up, please. Just information on Dr. Robertson and myself, which if you don't have these slides, we'll make sure you have access to these slides. And there is information later about phone numbers and such. This is really what I want to talk about is self-care as an imperative. There is the self, and what I was just talking about is systemic changes that go on. Self-care is also an ethical imperative. You have a duty. You have a duty to not harm. You have a duty to do well for your patients. And we're going to talk about where it is that I am, as Dr. Robertson was talking about, where is it that I shift from doing okay to not doing okay, and how does that influence my capacity to be servant-oriented in terms of effectiveness for serving patients that I work with, as well as the organizations that I function in. Self-care and wellness. We're talking about the psychological, emotional, physical, relational, and spiritual aspects of it, mind, body, and spirit. The role of self-awareness and self-monitoring. If you're not familiar with, make a reference to Daniel Goleman, and I'll talk about his work. Daniel Goleman was a Goleman. Dr. Goleman was an educational psychologist, and his work is kind of universally true. He said that his primary focus was elementary and middle school children and students, but it's relevant in the adult world. And when adults started to read his material and became familiar with him, they said, Dr. Goleman, we need this in corporate America. We need this everywhere. And so he then began to write to them as well. But what he's basically saying is that being able to be, and I'll show you a graph on this, be able to identify where I am when I'm out of balance, and to be able to intentionally be aware of what draws me back to balance, only then can I be effective in serving others. And so when you all are cutting your teeth in a highly critical time with COVID, Dr. Robertson was talking about dealing with AIDS epidemic in Oklahoma City, which you've gone through 2 now. But to sort of grow up professionally during COVID is a really challenging aspect of kind of cutting your teeth on pacing yourselves and the stress that goes on in the environments that you're in. More critically, that we have a self-care model. I'm going to talk about positive career sustaining behaviors. Some of you are very familiar with some of those. Maladaptive coping strategies. Some of you are very familiar with some of those as well. We all have the potential to be involved in each of those. This is not, I'm not going to read through all of these slides, but my general presentation to you today with some of those is that this is not a new phenomena, okay? Neurasthenia, 1869, okay? Basically talking about fatigue of professionals. We've been looking at burnout and fatigue for a long time, but it's, again, more relevant and extremely relevant during these COVID and sort of post-COVID times. Burnout, again, studied in research in early 70s. Emotional exhaustion, depersonalization, disengagement. You know what it is to be involved and to stay present. And then you know what it is to sort of not be there. And that stepping away emotionally, that kind of disengagement is a part of burnout because we need to be very present with our patients. Negative self-evaluation of one's efforts. Basically loss of sense of self-worth, loss of sense of self-esteem professionally. And these are all diagnostic indicators that in some level I'm not doing well. Resiliency versus resistance and advocacy. Resiliency is kind of an individualized element of coping and coming back. Dr. Robertson was talking about growing up individually as a young man, growing up professionally as a young professional, and knocking the top off of things. Oftentimes when we are counseling or consulting with an individual and they're not knocking the top off of things, there's a real tendency to feel like I have no value, or I've never really been of value, or I have the inability to get back to that. And the starting place for me is, what was your former state of excellence? Where were you knocking the top off of this? None of you would be sitting here today if you don't have a history of a former state of excellence, and probably still have right now. But 10 years from now, if you got 3 kids and a mortgage and a teenager who's acting out and a wife who's got precancerous tumors and your parents are that sandwich generation are getting ill, and you're going, holy mackerel, I'm just kind of overwhelmed with things. Where was that former state of excellence? Because you have it, and you draw back to that. And that's predictive in terms of recovery. That if someone never had that, if they struggled their entire life, then the expectation of trying to teach them new skills in their adult life is a different challenge. But bringing someone back to, assisting them to get back to how they functioned better before, and reminding them of what that took and what kinds of variables weren't present at that time as their capacity to do better self-care. That's relevant in terms of resiliency. Resistance and advocating within systems. And if you're not, consider when you get into your profession, when you cut loose of school, being part of associations, be part of OSMA, Oklahoma County, Tulsa County, AMA, advocating for change, advocating for how things function is where we don't just settle for or get overwhelmed by the systems, but we have influence for the systems to be able to regulate this differently. And again, as Dr. Robertson was talking about, I'm very excited about who you are and being able to bring this forward now. Dr. Robertson, if you could speak to how much electronic medical records were you dealing with at this stage? How much RVUs were you dealing with at this stage? You all have stressors that didn't exist, okay? The fact that the nature of medicine has become somewhat corporate in structure, and that's a necessity right now in terms of the economics of it, but there's got to be a balance in there. There's got to be a balance in terms of the energy and the capacity humanly for you all to do and provide effective treatment in medicine without being overburdened by numbers and without being overburdened by excessive requirements of unrealistic at times paperwork. So common, and you all have this, I'm sure. When I talk about self-care and what are you doing on the weekends and what are you doing on your days off, people laugh, say, Tobin, I'm doing paperwork until 11 o'clock at night, and then I'm getting up, getting my kids to school, and I got to keep up with the RVUs. And I'm thinking, wow, it just becomes kind of feels like the pace of it's got to slow down in some way. And where I'm pointing to at this point is that's the systemic issues. They are what they are. You're not going to change that immediately, but be aware of them and have a willingness to participate in associations and groups to have influence to see if there can't be better balance. Having doctors involved in administration and having input in terms of what's realistic, I think is critical for you all to have good balance in your lives, professionally and personally. So this is kind of the continuum, stress, distress continuum. Stress is a necessary part of our lives. If the alarm goes off on Saturday morning and you really don't have a whole lot to do, and you're thinking, why did I set that for 7 days? I'm not working today. Is that a stressful time? Do you get up anyways and get showered and get dressed and act like you're going somewhere? Probably not. Really, if it's your day off, unless you're going off to have a blast doing something that's really fun for you, there's a whole lot less stress on Saturday, using Saturday as an example of a day off. For many of you, it's not at times. But Monday morning, that stress, that alarm goes off, and it motivates you to become active, to activate your readiness in terms of what you're going to do. And so stress, at some level, is necessary. Distress is the weightedness of that stress. It's a little bit extra. It's more than what we would prefer, but it's still okay. It's part of life. It's part of what we cope with. And I'm going to talk about ranges of capacity for emotionally coping and self-care. Impairment becomes something different. If we drift into impairment, okay, today, what are the resources? How do we reach out? OHPP, the Physician Wellness Program, personal counseling, and it can be just talking to your partner, talking to your spouse, talking to your friends, talking to your colleagues. But if I'm reaching a level of shortening my sessions with patients, missing some of my paperwork and feeling the stress that I'm carrying behind for 2 weeks, not eating well or overeating, undereating, letting go of all those self-coping, positive coping strategies, and then I slip into impairment. And then at some point, impairment chronically generally leads to improper behavior. Okay? And so what we're trying to do is assist in keeping everybody at a continuum above all that. We'll talk about strategies to do that. You've probably had some feedback already on different versions of what burnout is, but it's basically a depletion or an exhaustion of our mental and physical resources, attributed to chronic or prolonged capacity to kind of have to manage it unsuccessfully on unrealistic expectations, either myself or the organization. And so when we reach that point, and you can be exhausted at the end of a day, you can be exhausted at the end of a call, but at some point I've got to be able to regroup and pull myself back in so that I'm not just, the heck with it, kind of giving up on it. Why did I get into medicine? What is this about? When I'm starting to reach some of those emotionally overwhelmed as well as physically overwhelmed places, that's where burnout starts to set in. Again, COVID, I think, accentuated that. We all have an emotional set point. And I'm going to see if I can skip ahead to, I'll come back to it. Yeah, on the top left is what I call, this is Daniel Goleman's work. On the top left is all of our emotions. And in there somewhere is a set point of somewhere between 1 to 10, 10 being my hair's on fire, I'm overwhelmed, 1 being that I don't have any energy and I'm kind of withdrawn. And so during normal times, we may wake up or be ready to kind of approach and deal with things that are on a 3 or a 4. And when stress kicks in, we go up to about a 7 or an 8. During COVID times, the set point moved up. The set point was advanced. And we didn't have, if you will, the luxury or the capacity to begin at a lower level. And so we had a greater vulnerability in terms of being able to sustain or manage keeping ourselves in a better balanced place. And what I want you to think about is under self-care, what are the kinds of efforts that you make? What are the kinds of behaviors that you have that would bring you back into a greater kind of center balanced place? I'm going to ask for hands here, but if I said, man, that guy is, or that lady is really, really in their best place right now. They're really in their zone. What does that mean to you? They're really in their zone. Anybody? Yes. Okay, thank you. Thank you very much. If you think about that same application in performing arts or in athletics or in even just kind of taking a test or something, when we're in our affective zone, we're very present. I'll keep on the side. We're very present. We're not at too low of an energy level, but we're not too agitated or distracted either. And when we're in that affective zone, that's when we're, again, at our greatest capacity to be of servant to others. When we're outside of that, and what kinds of things take us outside of that? Well, we're just talking about those factors of burnout, elements of personal or systemic issues that lift us into taking us outside that affective zone. Goldman's concept, when he talked about this with elementary and middle school kids, was that if they were bullied, or their parents were fighting, or their dog got run over, or something happened on their way to school, and they come into the classroom and they're trying to study complex learning, and they just can't. They're unavailable emotionally to be able to use the prefrontal cortex. The amygdala is taken over and hijacking them. Okay, that kind of brainstem. Well, that happens to all of us. That's a part of kind of who we are. And so his model in terms of self-care and dealing with burnout and dealing with emotional balance is to find what he calls here in window 2 across the top, self-regulation through self-awareness. What are the kinds of things that we do? Now, third-year residency. Is there still time to have lunch with friends? Is there still time to go to the gym? Is there still time for meditation, yoga, stretching, hiking in Colorado? How many of you are, if you're doing that, you're probably playing hooky. Nobody's raising their hand. Okay. When could you last do those kinds of things? That if you were falling, and if I could suggest to you in this model, when we're talking about young people, if 5 is perfect balance, okay, well, we can't expect 5. Okay, that's just unrealistic. So we've got to expand that because we're going to get sometimes low energy, sometimes we're going to get hit with high stress. And so we've got to have a capacity to expand our capacity to function. Ideally, we can do a 2 to an 8. 2 to an 8. Wow. I think COVID, ERs, anything in terms of the hospital at that time, starts at a 6 and moves up to almost a 9 immediately at the end of a 12-hour shift, especially if you're taking call. So your all's capacity as third-year residents to expand that functional ideal performance state is about going to window 2 and being able to find those strategies and skills that bring us into a better place to be present. I'm going to kind of skip around on some of my stuff here, but I think it's relevant to throw this in. Selflessness is the capacity to be present to those around you, and think about a doctor-patient. Selflessness is the capacity to leave my stuff outside the door and come in and be very present to those that I'm working with. Well, window 3 is that. Window 3 is compassion, empathy, awareness of the experiences of those around me. And if I am outside that affective zone, emotionally, physically, spiritually, all the different stressors that hit us, then my capacity to be present to others, generally present to others, is impaired. And this gets back to the impairment piece. Is it just simply because of the emotional component of that, or is my window 2 self-management because I can't run as often? I'm not meeting with my friends for lunch on a regular basis. I don't even practice meditation or yoga or get to an exercise class. So maybe I'm overeating. Maybe I'm oversleeping. I'm just sleeping when I'm not doing anything else. Maybe I'm drinking or using other drugs. Maybe I'm, and some of the newer drugs today, and I'll throw this out to you generationally, but if it wasn't jogging and it wasn't lunch with friends, how many of you was it binging on video games? Okay, it's kind of a gender thing. I think more men than women. So there's probably another element there of Facebook or something else that relates to both genders. But those can also be overused versions of just kind of numbing ourselves. We numb ourselves with lots of different things. Okay, the problem is when we numb ourselves, we don't recharge. And so those are more negative behaviors that go on in window 2. Being intentional in window 2 to bring ourselves back into that affective zone is really key to what we're trying to talk about here today. Because then when I go to window 3, when I'm with patients, when I'm with loved ones, when I'm with others, including when I'm with myself, I have a greater capacity to understand what's going on and to connect effectively. Working with patients is really what window 4 is all about in Goleman's model. Collaboration, problem solving, treating, diagnosing, being able to, diagnosing can also be a part of window 3, which is really sort of getting them, but then being able to have a good and effective plan with them. So if you allow this model, it's really linear, that window 1 is always on. Window 1 is always about where am I? Window 2 is about me being able to pull myself back into an effective zone when I fall outside of it. And what do I need to do to be able to do that? Well, again, there's the formal programs. The last program you want to be dealing with is the board, okay? And I don't mean to speak bad in any way about the board, but I don't want to be in trouble in impairment and problematic issues. And so this is sort of in the sense of preventative effort to understand how do I just stay in good balance, in general good balance, personally and professionally. If I need to reach out to an OHPP support system, I have a capacity to ask for that. If earlier on that continuum of support, the physician wellness program, and I'll talk about that a little bit later, but that's basically 8 free consultations about stressors in my life. Everyone has access to that. That's part of this room. It's not therapy. It's basically personal consultation about stress or things that are going on in my life that I need some help and direction with. Sometimes it's more systemic issues than it is personal issues. But these are resources, but you have other ones that you know and you've applied most of your life, but we really get pretty darn busy. And my encouragement here today is just to encourage you to be intentional about staying or finding that I have a greater capacity to redirect myself back inside a window 1 range that allows this thing to flow well. If not, we get to window 4 and it's my way or the highway. And it may or may not be effective. When I'm out of balance in window 1, then I'm less than 50% effective in window 3. I'm less than 50% effective in terms of understanding and really connecting well with others. And it's that error that then can lead to problematic aspects in my life. So any questions about Goleman's model? I use it all the time. I really believe it to be a universal truth. And it's just a kind of a lifestyle perspective. Learning how to be and getting better at self-awareness and being honest with ourselves in regards to self-awareness is just a really important part of sustaining and being in balance. And being intentional about it is really, really valuable. Any questions on that aspect of it? Okay. I'm going to go back up. Again, adaptive versus maladaptive coping strategies. Being able to understand that 0 point is very similar to the other model 5, that when we get into the plus range, these are just aspects of normal stress that we deal with all the time. What we're trying to organize and prevent is going into the negative stress and distress, getting into impairment, and getting into where at some point that impairment leads to unethical or improper behaviors in our lives. We're all susceptible to the potential of that. And so we have basically a responsibility to stay out of that. Okay. Burnout creation and prevention. Things that lead to burnout that we need to be aware of. Work overload. How much influence do you have about work overload? Do you walk in on your shift and say, "I'd like to have a light load today, please"? Could I have a light week, please? Sustainable workload. But now, when I talk about earlier the capacity for advocating systemically for change or balance, this is where I think it's really valuable. You may or may not have direct influence immediately, but being able to understand that what really is realistic workload. And can I consult with my colleagues? And can I consult with my supervisory folks, chief of staff, the higher professionals that are supervising my work? A lack of control, feeling of choice. Again, during residency, you don't have a whole lot of choice. Absence of community versus a supportive community. In some of my work with the Physician Wellness Program, one of the things I talk with your colleagues about is how is your current rotation offer you a supportive community? And in some circumstances, people are feeling very isolated. And in other circumstances, people are feeling like, I love this group. My current rotation is really balanced for me. Are you on that introversion, extroversion scale, finding the value if you fall more towards the introversion? And oh, by the way, welcome to 70% of the population is introversion. Is that capacity to reach out and have what I call informal coffee drinking or just conversations with my colleagues, whether it's the other residents, whether it's the nursing staff, whoever is present. Don't be isolated. Don't be the Lone Ranger when you're sitting around others where you can have that support. Participate in some of that. It has value to you. A sense of fairness and respect is really valuable. Is this a good job fit? Well, part of your residency process, going through different rotations, is to determine, is this a good fit? Do I work well at the VA? Do I work well in the ER? Do I work well on this unit or that unit? You're sorting out where it is you're going to try to land professionally. But being able to be intentional about how that fit works for you. Are you familiar with vicarious traumatization, secondary trauma? How many of, just think to yourself, but how many of you experience exposure to more serious illness during the COVID times in your early residency than you had ever anticipated that you would? And for some people who are in ER settings or ICU settings or different places, saw a lot of death. But just the capacity to walk in and feel safe. You know, we're sitting here with no mask today. We're probably coming back to mask with winter. But 2 years ago, we wouldn't be sitting here with no mask today. And it was a different environment in terms of feeling safe. Not only our own safeness, but then watching the trauma around us. So much trauma over time creates a secondary trauma. And are we aware of that? Or do we take the position, well, I'm a physician and I need to just handle this. It's part of the routine. I'm supposed to do this. None of my other colleagues are falling out. Why would I be falling out? Be aware of that. The other is compassion fatigue, a reduced or constricted capacity for empathy. Now, again, if I go back to the Foursquare, that's me not doing well in window 1, hindering or constricting my capacity to do well in window 3. So compassion fatigue and vicarious traumatization is part of things we intentionally, it's critical for us to pay attention to. Again, can I talk with somebody about this? Can I do some things that bring me back to a greater capacity to navigate with greater compassion and less vicarious traumatization from the experiences that I'm having? These are just some things that contribute to poor self-care. Sometimes you can feel that there's a lack of administrative support or there's a lack of collegial support. Not everybody's going to just wear their emotions on their shoulder and just kind of share those with you. But if you're feeling that nobody's paying attention, then I may need to reach outside the system for support. Too little fun, too little humor. Are you good at bringing humor or fun into your rotations? Are you the jokester? Some of you are smiling. You know the jokesters in the room. Doesn't have to be overt joking, okay? But just the capacity for uplifting energy is a critical part of this. It's hard enough. Make sure that you, if you can, be intentional about advocating for lightness. I'm going to give you an example that one of my older brothers, I have many siblings, one of my older brothers worked in a steel mill in the Syracuse area. This is back in the early 70s, or no, I'm sorry, mid 60s. And I don't know what the temperature was in there, but it was extremely, extremely hot. Imagine about a 3-story building with the chains where you pulled the windows to open them up. And he worked with a gentleman who was much older than him. My brother Jim was in college at the time. And Jim went around opening all the windows. And this older gentleman came around behind him and closed all the windows. And Jim said, what are you doing? He goes, we must work hard. There is no room for pleasure here. We must work hard. And I thought, gee, you're in a steel mill. He was wearing one of my jerseys and it was coming back with holes in it from the steel that was sparking off of these big caverns of liquid steel. But the environment for this individual was, there'll be no fun. We don't get paychecks if we're having fun. Wow. Okay, I don't think that was really a good mental health plan. So you may have curmudgeons around you, okay? You may be somewhat of a curmudgeon when you're burnout, okay? Try to shift gears a little bit. And I'm not trying to say the whole thing's humorous and funny, but bring lightness to the experience when you can and feed that with each other. It's about uplifting. Limited understanding of our own needs. Again, that's kind of back to it being intentional and practiced at it. How much experience do we have? Do you have 20 years experience? Do you kind of know you've seen this before? Now, we're in a new time, so, you know, Dr. Robertson has sort of seen this before, coming through one pandemic into another pandemic, but being able to just have enough kind of knowledge or experience in life to be able to kind of make sense of things, to reduce my stress. Life-giving events, what are those? Again, that's kind of back to what do I do in window 2? And my capacity to say no and set boundaries. We're pretty servant-oriented. I don't think there's a whole lot of selfish people in the medical field. And so I think it's really critical. I mean, you can feel selfish sometimes, or you can feel like, boy, that person's really selfish with that person. But for the most part, we're very servant-oriented. And so our capacity to set boundaries, you guys go on, I'll take care of this. I got this. And then I never get done doing whatever this is, okay? I've got to be able to set boundaries around me in various places to hold balance. If you're not familiar with, there's great books on boundaries. But it's a critical part of healthy lifestyle. Back to my brother in the steel mill, that individual would also probably say, no boundaries. Everybody's involved, okay? But we've got to have them in terms of being able to survive. Consult. What did you just see? Anybody? Looks like two-headed horse. I don't know. Something. Okay. Sometimes you're going to see something and you're going to put it in the note, or you're going to operate from the diagnostic perspective, and it's like, I don't know. Was that two horses? Was that a two-headed horse? Was there three horses? I don't know, but we're going to get a treatment for it. Wow. What do? Do you just plow through and treat the two-headed horse or the three horses when there's maybe two? Or was that just a mirror? What the hell was that? Actually, it was two horses, one standing in front of the other. But what I want to offer to you and suggest to you very strongly is that when you are uncertain, rather than err, to get it done, again, out of exhaustion, out of burnout, out of I just got to get through this, consult. When you don't know, consult. One of my consultations, probably about a year and a half ago, was a young professional who was overwhelmed with an outcome of a medical experience and reached out for help. And my consultation was not psychological. My consultation was organizational and systemic. Have you talked to your department director? Have you reached out to your HR? Do you know what legal would say about that? Don't be the Lone Ranger in this thing. Get some help, consult. Risk management, consult. And so that's part of self-care, is being able to go back and get safety, be safe where you are in terms of what you're doing. This is sort of that model that we have to be aware of in terms of what can occur to us. We get to burnout, we get to compassion fatigue, we have vicarious trauma, we have ambiguous endings. How did that go? I don't know. I never saw really what happened. I worried about that patient, but I never saw the outcome. Professional uncertainties. In the middle of all that is good self-care to reduce the risk of these things. I've got to be aware that when I'm feeling these and I'm feeling kind of caught up in like it's going down the drain, I've got to reach into that capacity for greater self-care. Self-care is for others. I'm doing fine. Shouldn't be a problem. Especially early career physicians, I shouldn't have stress. I'm too young to have stress. I don't have enough experience to have stress. Being perfect at self-care is expected because we're physicians. We really shouldn't have stress because we're physicians. Okay? Self-care is kind of that wacky new age thing. Come on, who needs this? And these are all myths that keep us from reaching out and getting that. I want to just touch base on the ethical real quick. And again, you probably have access to these handouts. But do the right thing. Do the right thing is a commitment and an obligation that we have, benevolence and non-malfeasance. Physicians need to be self-aware so that we're not causing harm towards others. We need to be competent. And our capacity for competency is based on our energy level and our capacity to function effectively, to be in that effective zone. We have an obligation, professionally, ethically, to be in that effective zone. Last thing I want to be is at a board meeting justifying my competence. Okay, well, I was tired. I had worked 14 hours for some reason. Something happened, somebody left something and I didn't know what it was. Back to the two-headed horse, and I assumed this and did that. Okay, these are responsibilities that we have, and again, why we're talking about avoiding harm and maintaining competency is a part of our mental health. I know I'm going to run through this real quickly. After this, I'm going to pause and see if there's any questions. How many of you have ever heard of CBT as a psychological cognitive behavioral therapy, cognitive behavioral techniques? I sat with Dr. Mackenbaum twice. Fabulous man. He's in his 80s. He developed this program, developed this theory, and then the techniques that go with this. But the simplest application of this is 12 o'clock, something happens. internally in terms of a trigger or externally in terms of an event. 3 o'clock we have no control over. 3 o'clock is the brain's capacity to create adrenaline, cortisol, all the stress hormones and endorphins. 6 o'clock is key. 6 o'clock is key because we get triggered in terms of stress. Our brain goes to the amygdala, fight, flight, the primitive brainstem. And if we don't interrupt it, we go right to 9 o'clock in a reactive pattern. And then we just repeat the cycle. We get triggered internally or externally. Brain chemistry is released. We skip the capacity to pause and balance this out, and we become reactive, and we just stay reactive, and we stay in this cycle that's really hard to break. And Mackenbaum's concept is we've got to hit the pause button. We've got to slow down when we feel it. Again, this goes back to that previous model. Are we aware? Do we feel what's going on? Do we sense our headache, our chest is tight, our gut is upset? What do we know that's telling us to pause and get perspective? The prefrontal cortex is a really, really, really good tool. Okay, thank God it's developed over thousands of years. If we're all functioning on amygdala, we wouldn't function very well. But thank God it exists. If the building's on fire, we've got to be able to react. So we got to have a balance between this emotional response and the capacity to process information and think through things. But we really want to be able to pause and re-engage this because it's the most powerful tool we have. Reasoning, logic, compassion, the ability to balance this, the amygdala. And that's this whole concept of CBT. When I'm operating on an irrational perspective, I've kind of become reactive. And I want to move out of that pattern by learning how to be self-aware and then pause and redirect myself into a more thoughtful, informed strategy. Now, sometimes that pause is reach out for consultation. Colleagues, friends, supervisors, different programs. Sometimes that pause is just step back, take a deep breath. I know how many of you are familiar with abdominal breathing. It's part of labor. It's also part of yoga and meditation. Like biofeedback, abdominal breathing will just significantly reduce our stress level. It will disengage the amygdala greater than any other tool. Another one you can do immediately without having to go elsewhere is just what we used to talk about in the military is isometrics, where you tense your muscles and you hold them and then you release it. And you tense them for 3 or 4 seconds and then you release it. The body has homeostasis. It has its capacity to relax itself and reset itself. Between abdominal breathing and muscle tension, muscle release, you can do that in the OR, you can do that in the ICU, you can do that while you're studying or taking an exam. You don't have to get to a yoga class. You don't have to go run 5 miles. You can do it immediately. It's breathing, relaxing, and relaxing our body. Where I'm going with that is that's part of that pause. That's what helps us re-engage our capacity to function more effectively. So I know we're going to run out of time here. Okay. Does anybody have any questions? I know I kind of ran through this pretty quickly and I've got a lot there. The only other piece that if you don't, I would like to say is that if you're not familiar with the Physician Wellness Program, it is available statewide to every medical student, every resident, every intern. Okay, here. Put the numbers up. Yes. These are the numbers, and you have those slides. That's the Oklahoma County program. That's the Tulsa County program. And that's the statewide. The Tulsa number is different than the Oklahoma County and the OSMA. I'm the contact person on both Oklahoma County and OSMA. And it's a simple anonymous call. It's not therapy. It's consultation. There's no diagnosis. There's no electronic record. You're just coming for help. And it's early intervention, prevention effort for support. Like I said, people come sometimes because they got external stressors going on. People call sometimes just because they're kind of overwhelmed with the current circumstance. And we just kind of talk through and kind of process to get them as I was demonstrating with the CBT and with the Foursquare, kind of lined out back to their greater state of excellence, trying to get them back into a place where they feel a greater balance and in that more effective zone. So that's a free service to you all, 8 free sessions annually. OHPP is a whole nother program, which is fabulous. All kinds of support systems and programs within that.
We can connect you back and forth, though, as you get more in.
Prevention. Yes, yeah. The wellness program is confidential. It's consultation, no diagnosis, no electronic records, no fees. So it's just an advertisement for some self-help. So that's all I have. And if there's any other questions, if not, we'll conclude. But if you have some, I'm glad to hang around afterwards. Test.
Okay, we are reaching the end of the sitting in here and listening to people, which is great. A little bit. As I was introducing, I'm sharing more on the vice president of risk at FICO. FICO is the malpractice insurance carrier that insures all of you in your residency program. Whichever one you're in, we have both. And we're going to talk with you today about malpractice insurance. And the title of our program is NPL 101. And how I know that doctors don't know very much about it is a couple of weeks ago, we had a summit, and we actually offered this as a program, and the doctors would say, what is NPL? Well, medical professional liability insurance. We're trying to start saying that instead of calling it malpractice insurance. It really is about protecting your profession and the liability that it takes. And joining me today is Corinne Logan. She's an underwriter for FICO. She's a BBA in accounting from the University of Oklahoma and a BBA in accounting from the University. She's been doing this for more than 10 years. She doesn't look like she's been doing it that long. In her current role, she serves as a physician service underwriter for FICO. So that means she evaluates risk profiles and determines pricing for the conditions to apply for insurance with our company. In addition to her underwriting role, she proudly serves as ally engagement chair for Metro Pride and is a structuring coach for the Foundations of Insurance program, where we partner with HPC throughout the country to educate students on insurance topics and career opportunities and benefits. So she and I are going to tag team a little bit today. And like I said, okay. We're going to talk about malpractice 101. What, a couple of years ago, I had sort of an epiphany about how, I've been doing this now longer than many of you have been alive on this earth. And so, as I talk to physicians, I understand that they don't have any understanding about their insurance coverage. And a few years ago, it just came, I had 3 days of injury. And basically, I had one of my physicians who has residents working in their office, we mentioned that to you, called and said, hey, I've got the student, they want to talk to you about claims issue. And does this every single day. And she will talk to you about the different types of coverage that Corey alluded to when she talked about contracts.
So like Sherry said, I'm Corinne Williams. I'm an underwriter with Plico. My voice does carry, but not as well as Sherry, so I'm going to use the mic. All right, so I'm going to help you guys walk through when you look at insurance coverages, what some of your options are and what some of those different options mean. So we're going to look at policy types, limits, what consent to settle means, and then selecting a carrier. So there's two main types of medical professional liability. We have occurrence policies and we have claims made policies. Some companies offer both. So Plico and MedPro both offer both of these types, but there are many companies that will only offer you claims made coverage. So occurrence coverage means that you are covered if the incident occurs, hence occurrence, when the policy is in place. So if the policy is in place when the treatment or the incident occurs, you have coverage under your occurrence policy. With claims made, you're covered if the policy is in place when the claim itself is made. So not when the incident occurred, but when the claim is made. If your policy is in force, then you have coverage. So let's look at an example. So we have two incidents that are occurring. We have one thing happens in 2021, one thing happens in 2022. And then each of those ends up becoming a claim, both of which are filed in 2023. So let's look at how these two policies would cover this. So for an occurrence policy, because the incident occurred when your 2021 policy was in place, you would have coverage under that 2021 policy. When the 2022 incident occurred, your 2022 occurrence policy is going to cover that claim, because it was in force when that incident occurred, because this is occurrence coverage. So even though these items were filed after the fact in 2023, you're still going to have coverage because the policy was in place when it occurred, okay? And one thing to think about here is this is two different sets of limits, which we'll get into that more when there's limits, but here you've got two different policies covering these. Okay, this is what the claims made one's going to look like. So the incident occurs. This policy has been in force for 3 years, just like the occurrence policy. So an incident occurs in 21, incident occurs in 22. Both are filed in 2023. Because the policy is in force in 2023, both of these claims are going to be covered. But if you notice, they're both going to be under that 2023 policy because it's triggering coverage when the claims are filed, not when the incident occurred. Okay? Any questions on that so far? I know that's like a lot of jargon. No? All right. We're going to look at it a little bit different way. So this is pretty much the same thing, but we're just going to put it up there differently because I know, everybody learns a little differently. So let's say that you get sued during the policy period for something that happened during the policy period. If you have occurrence coverage, your policy is going to protect you for that. Now let's say you get sued after the policy period. So this is the example that we had on those previous two slides. You're sued after the policy period for something that happened, something that occurred during the policy period. You're still going to have coverage for that if you have occurrence coverage. All right, now let's look at claims made. So if you get sued during the policy period for something that happened during the policy period, you're good on claims made because the claim was made while the policy was in effect. But let's say that you get sued after the policy period for something that occurred during the policy period. In this case, there's not going to be coverage because the claim was filed, the claim was made after the end of the policy period. Now, we do offer something that is going to help cover this gap because if you have a claims made policy and it cancels, everything that happened during that policy is no longer covered unless you purchase tail coverage. So you're going to probably hear this a lot throughout your career. Tail coverage is basically an additional add-on to your policy that covers that time period that the policy was in place. It's not needed on an occurrence policy because as long as it was in force when it occurred, no matter when that claim is filed, it can be filed 20 years down the road. If you're a pediatrician and you treated someone when they were young, and that statute of limitations doesn't start and you get a claim filed 20 years down the road with occurrence coverage, it does not matter. It's still going to be covered. But with claims made, you would need to purchase tail coverage to cover you for that time period that the policy was in place. Sometimes you'll hear it called an extended reporting endorsement. Basically, all that means is that it's adding an extended reporting period onto the end of your policy. So here we can see how this changes this scenario with the claims made coverage. So if you did not purchase tail coverage, then if you get sued after the policy period, there's no coverage. If you purchase tail, you've got that extended reporting period, meaning you have an extended time for claims to come in, and the policy is going to cover. Any questions so far on any of that? Yes. Tail is generally going to be indefinite. So the only tail policy that Plico and MedPro sell is an indefinite tail policy. So it's going to cover you forever. There are carriers, I will tell you, that offer like a 2-year tail or a 3-year tail. So that is something that occasionally is out there. We don't feel that that's enough coverage, and so we only sell the indefinite. Yes. Mm-hmm. So it's a one-time payment at the beginning of the term, which I think may actually be our next slide. So it is due at the time that the policy cancels, generally within 30 to 60 days. Yes. Yes, so every time you have a claims made policy and you cancel that policy, so let's say you work somewhere for 4 years, cancel that policy, then you go somewhere else. Every time you have a claims made policy, you would need a new tail policy for that term. Any other questions? All right, let's keep going. Okay, so here's your question about tail cost. So tail can be very expensive because essentially you're buying coverage for everything that happened while that policy was in place. So it can be up to 2 to 3 times your annual premium. It is typically due 30 to 60 days within at the end of your policy. Plico is 30 days. There are other carriers that are 60 days. This is something I'm sure Corey probably mentioned this to y'all earlier, but when you are looking at contracts, this is extremely important because you can negotiate sometimes to have this covered for you if you were to leave the practice. So let's say you go and you work for a group and you decide that you want to move on from that group after 6 years. If you don't have in your contract that they're going to pay for your tail, this could potentially be on you to pay 2 to 3 times your annual premium at the time that you leave. So you want to start thinking about that at the beginning of your contract negotiation, not when you're ready to leave and move on to somewhere else. There are also, a lot of times with hospital employment, they will build in the tail to the coverage, and so you won't necessarily be responsible for it, but you want to make sure that you understand how this is going to work preemptively. Okay, so here's a little bit of a scenario that could happen. So let's say that we have a doctor who's been practicing for 15 years. The office manager was the one that handled the MPL. So the office manager is paying the bills, the doctor's practicing medicine. Doctor's not worrying about this. Okay, so the office moves and the bills stop getting paid and that policy ends up canceled. And the office manager makes the decision down here that they're not going to buy the tail coverage. If this were to happen, all of those things that happened while that policy was in effect, there's not going to be coverage for. And I'll tell you, once you miss the due date on a tail, you're not getting it. It's a pretty strict industry-wide rule that those tail due dates are pretty set in stone. So pay close attention if there's ever an office move, you move employment, et cetera. You really want to make sure that if you have claims made coverage, you're paying attention to this tail. Okay. All right. So with occurrence, there's not a need for tail coverage, but there's a additional cost generally to occurrence on an annual basis. So your occurrence coverage generally is going to be a little bit more expensive than your claims made coverage, but it can save you money in the long run when you're not ending up having to pay for tail coverage. And like I mentioned earlier, it's not offered by all insurers. Okay. All right, so policy limits. So this is the most that your insurance company is going to pay in the event of a claim or an incident. You may have seen limits before on other policy types. Obviously, your health insurance generally has like a maximum that they'll ever pay for you. So same thing here. Each policy is going to have a limit of what it will pay for in that policy term. Our most common limit right now in Oklahoma is $1 million, $3 million. It's $1 million per occurrence, $3 million per aggregate for the policy period. We do sometimes see physicians carry more limits than that. It just depends on what their contract status is. With most of the health insurers require at least a $1 million, $3 million to be contracted with them. So that's definitely by far our most common limit. Okay, so here's where we get into why occurrence is slightly more expensive. Part of it is the tail coverage not being there, and as an insurance company, generally the claims are going to cost the same, whether they're an occurrence or claims made. So we're needing to collect a little bit of extra premium each year versus collecting it at the end. But here's the real reason why it's slightly more expensive. With occurrence coverage, if you have 35 years of occurrence coverage, every single year you're adding a limit. So each year, only the things that occurred in that year would be covered under that policy. And then the next year, you're getting a whole new limit for everything that occurs in that year. But with claims made, if you have a claims made policy for 35 years, you only have the limit of your active policy year. So if you've had that for forever, all those incidents that could have occurred over those 35 years are all going to fall in the most current year because it's the coverage of the year the claim is made, not when it actually occurs. Does that make sense? It's a little tricky. Okay. That's all right. It's tricky. So yes. Yes. Correct. Yes. So you could, say you had something filed in 2024 with a claims made policy, and then you had something else filed in 2027, you would have a limit for each of those. But if you had something happen in 2024 and something happen in 2027, and they both got filed in 2027, only the 2027 policy is going to take effect. Whereas with occurrence, you're going to have the 2024 policy trigger for the first thing and the 2027 policy trigger for the second thing. So you've got additional limits available. Yes. Mm-hmm. No. So it renews each year based on when those claims are made. But if you have multiple claims in the same year, even if with a claims made policy, so if you have multiple claims made in the same year, you only have that one limit, even if those things occurred in separate years. But with an occurrence policy, you've got multiple limits because those are spread out throughout the years in which they occurred. But you do have a new limit every year. So if you had a claim filed this year and a claim filed next year and a claim filed the next year, you would have limits for each of those. Yes. Yes. So there are statute of limitations, vary by state, vary by what the incident was. It's kind of a complicated, I am definitely not the expert on what all the statute of limitations are. But yes, there are some statute of limitations on when a claim can be filed. And that, again, varies very much by state, by specialty. Like pediatrics is a good example because a lot of times you have age majority concerns there as well. However, obviously, we don't recommend that you rely on that as this is never going to get filed because there's statute of limitations. That is up to, legal interpretation and up to the legal system to decide whether they're going to allow that. So yes, it does exist. And obviously, over time, the further you get away from an incident, the less likely it's going to be filed past a certain point. But yeah. Did I see another hand? Okay. All right. So, Sherry, do you want to take over here? All right. Thank y'all.
And as I mentioned, our final speaker of the day is Mr. Sean Neal. Sean's the Vice President of Advocacy and Political Affairs at the American Osteopathic Association, and he's got more than 15 years of political and advocacy experience. His focus primarily on fundraising, government relations, and grassroots initiative. Sean currently heads the AOA's advocacy efforts at both the state and the federal level. And I know that there are some of you in here who have attended past DO Days on the Hill, so Sean's probably a familiar face to you. But we're very pleased that he took his time to travel to visit us from Washington, and so please welcome him now.
Well, thank you so much for that introduction, and I just want to thank the organizers for putting this on and inviting me. It's my first time to Oklahoma, so I'm really excited to be here, and Oklahoma has welcomed me with open arms, so I really appreciate it, and the same is true for OSU. I also really appreciated the last presentation. I learned a lot about medical malpractice insurance, and we're actually advocating for some bills that impact medical malpractice insurance, and we'll get into that a little bit later. But the whole time I was thinking, man, it is really, really tough being a physician. And that's, not even talking about your patient load and your student loans. You got to think about medical liability. There's so many things that go into it. And so we at the AOA like to think that we try to make your job a little bit easier as well by advocating for bills that impact you or will impact you in the future. And so, advocacy engagement in political affairs is super important because I think a lot of people, may not necessarily be interested in politics and lawmakers and meeting with them and things like that. But I guarantee you politics and lawmakers are interested in you and what your practice does on a daily basis. And so before I begin, I'm curious, how many people here have actually attended DO Day on Capitol Hill? Just show of hands. Okay, so we have a handful here or there. That's great. Anybody have a relationship with their lawmaker either on the state or federal level? Good. Fantastic. So we have a few. And so before we kind of get into things, I just really always want to define advocacy and what we do at the AOA. And so really it's just to influence lawmakers on decisions that they are going to make. And so we can do this in many ways, right? We can ask them to co-sponsor bills. We can ask them to vote a certain way. We can share ideas and stories, provide information. But there's many different ways to do it, and not all strategies are necessarily created equal. And so we at the AOA, we advocate at all three levels of government. So we do it at the local level, we do it at the state level, and we do it at the federal level. And so what happens is, as you get further and further up the pyramid, legislation and passing health policy becomes slower and slower and slower. So passing legislation really can be a glacial process, and it can take years and years and years. Since I've seen laws that have taken more than 10 years to pass that we are working on. So when you're engaged in advocacy, it's really important to keep in mind that you have to be resilient. And so this was a study, and I'll go ahead and read it off for you in case it's hard to read. So a think tank in Washington, D.C. conducted a poll with Capitol Hill staffers. And so they asked a really simple question. If you're a member if your senator or member has not already arrived at a firm decision on an issue, how much of the influence might the following advocacy strategies directed to the Washington, D.C. office have on his or her decision? And so right here at the very top here, you can see an in-person visit from a constituent has a lot of influence. So 46% of the respondents said it had a lot of influence on their boss's decision. And then 54% in some influence. And then you kind of go down the chart here. So you have individualized post letters, 20% influence, personalized email, phone calls, etc. Now, I will say all of these strategies here are important. But some do have a higher priority than others, and it really kind of speaks to actually physically meeting with your lawmaker, because it does have an impact and it does have an influence. And so when we're engaging in advocacy as well, it's really important, I mentioned this a little bit earlier, that very few bills actually go on to become law. So here's some data from the 116th Congress, which was from 2019 to 2021. More than 14,500 bills were introduced in Congress, okay? Only 5 or 6% of those bills went on to the House and Senate floor for a vote. So that's only 746 of the 14,700 bills that were introduced. And of those that actually made it to the floor, only 300 were actually enacted into law. So when we're talking about passing a bill, you're really talking about 3% of bills that are introduced that actually go on to become law. And so we at the AOA do this each and every cycle. So it really is a truly elite club to be a part of, passing one of these bills. And I should also say that many of these bills that are passed are naming post offices or minting coins or something like that. So when we're talking about bills of substance, that number goes down even further. I was kind of interested the other day how many associations and organizations are representing individuals and groups of individuals in DC. So whether that's farmers or lawyers or whatever it may be, physicians. And there's 90,000 of them. So there's 90,000 associations advocating and lobbying for their groups of people. So the fact that we at the AOA are able to push through and represent you to pass these laws while competing against these 90,000 other associations, it's truly remarkable. And so it can't happen without physician engagement and support. And so quickly, I just wanted to talk about a lot of the problem too is breaking through the noise as well. There's so many emails and communications that go to Capitol Hill. So how can we actually break through that noise and communicate with the appropriate people actually to make a difference? And part of that is knowing the actual person to contact. And so here's just a simple congressional structure. Obviously, we have the member of Congress at the apex. They are, very busy, 80-hour work weeks, going from meeting to meeting to meeting. And then the chief of staff is right underneath of them. Now, the chief of staff, they're the only individual that can typically speak on behalf of the member of Congress. And then there's branches underneath the chief of staff, so you have policy staff. This is important why we know each policy staffer has their own respective issue and policy that they are responsible for. So you have health policy staffers, you have agriculture staffers, you have technology, et cetera. And so these are the individuals that are really kind of the people that you need to know.